everyone, or good afternoon or good evening, depending on where in the world you are today. Welcome to our virtual Rhinology 8 symposium with the title being Hot Topics in Rhinology. We've got a great panel today and some great sessions, and very much looking forward to having everyone participate. We will be getting started in just a minute, but first I'd like to thank the American Rhinologic Society for sponsoring this event. And also for our colleagues at Storz for providing sponsorship and helping this to happen. So moving forward, I want to quickly just go through the format today. We'll have three panels. The first is going to be dealing with skull base, and the second and third with inflammatory issues. It should be a 3-hour program, and we have a number of really great expert panelists from across the world. Course directors today, that's me on the left, Ted Schuman from Richmond, Virginia, Dr. Ed Kwan and Dr. Ashley Halderman as well. And we'll introduce the panelists as we get moving forward. And again, just a quick overview of the agenda before we dive right into the panels today. Session 1 will be moderated by myself, and we'll focus on skull-base pathology. Our first panel, we're actually going to switch these two due to some minor technical issues. So our first panel will be the multimodal management of spontaneous CSF rhinorrhea. And the second panel will be emerging options for locally advanced sinonasal malignancy. And then moving forward, Dr. Ed Kwan will host 2 panels on the first dealing with new options for treating chronic rhinitis. Second, for focusing on harnessing new technologies for patient education and practice marketing. And finally, last but not least, Dr. Ashley Halderman will host 2 panels, the first on best practices for initial management of nasal polyposis, and the second panel on exploring the proper timing and indications for the use of biologics in recalcitrant nasal polyposis. So obviously a very, very timely topic that's still being figured out in real time. So session 1, again, skull-base pathology today. That's me, just a quick introduction. I'm from Virginia Commonwealth University in Richmond, Virginia, rhinologist and skull-base surgeon. More importantly, our faculty today for our session, I'd like to introduce first Dr. Alyssa Illing. She is Associate Professor of Otolaryngology, Head and Neck Surgery, Chief of the Division of Rhinology at Indiana University School of Medicine. And we also have joining us today from South Carolina, but practicing in Maryland, Dr. Douglas Ray. He is at the Centers for Advanced ENT Care in Baltimore, Maryland, and previously for quite a many years was on the faculty at Hopkins. So both panelists really are going to be able to bring some excellent experience to this topic today. So we're going to start today talking about management of really recalcitrant CSF rhinorrhea. And my goal with this talk is not, in this panel, is not so much to talk about surgical techniques for repairing these, although if our panelists have insights, I think that's a great topic of conversation. We're happy to talk about it, or if people have questions about it, we can certainly talk about it. But as surgeons, we all know that these can be a very sort of frustrating group to deal with sometimes. You fix one leak and then they leak in a different spot. And often it is unless the underlying pathophysiology is improved, the problem doesn't go away. So I'd like to try and get our panel today to weigh in a little bit on how do we treat these patients as a whole to see if we can reverse the pathophysiology and have better outcomes. So I want to start just really briefly with the case presentation and then get it to the panel as quickly as possible. So this is someone that I had initially seen a few years ago, 45-year-old woman. She presented with new onset of seizures and headaches. She had watery right-sided rhinorrhea, no history of surgery, no history of trauma. She did have one episode of meningitis years ago. She'd been treated for idiopathic intracranial hypertension in her 20s. And in clinic, to my exam, she had a BMI of 45, so was morbidly obese, had a clear left middle ear effusion, and on nasal endoscopy had clear mucoid fluid draining from the right frontal recess, but no frank CSF dripping was noted with Valsalva. She had a CT and MRI for imaging, which showed multiple sites of anterior and lateral skull base dehiscence. So moving from front to back, she had a right supraorbital defect with fluid tracing down on MRI. She had a right frontal recess encephalocele. She had a right cribiform defect also with an encephalocele. She had question for a left-sided cribiform encephalocele versus a low-lying olfactory cleft. And then not pictured on these particular scans, she also had a left lateral sphenoid defect, left tegmen defect, possible right tegmen defect, and evidence of chronic elevated ICP. And here we can just see these additional defects, floor of the middle cranial fossa with CSF tracking down. And just a quick word on spontaneous CSF rhinorrhea, and then we'll turn this to the panel. These are about 14 to 46% of cases, typically associated with elevated intracranial pressures, which is strongly associated with obesity. These can be, as we discussed, frustrating situations because they're prone to recurrence at the leak at the same or different skull-based sites unless the underlying pathophysiology is resolved. So again, bringing it right to the panel, Dr. Illing, we'll start with you. Is there any additional workup that you would want to get in a patient like this prior to moving forward with treatment?
Sure. Yeah, I think the imaging that you obtained was really helpful. I usually try to get both the CT for operative purposes with an active CSF rhinorrhea, and also the MRI is really helpful to know the contents of all the skull-based defects, whether there's a lot of brain tissue versus just the meninges there. Kind of helps me plan for my approach and repair. I do try to obtain a beta-2 transferrin to help delineate the nature of the drainage, just to kind of confirm. It's just nice to have that available. I do also, if available, try to get a neuro-ophthalmologic exam to see if there is papilledema. Often there is not, but it's nice to have a baseline exam and have a relationship with the neuro-ophthalmologist, because I usually try post repair to have them seen by the neuro-ophthalmologist to monitor for that papilledema. And so those are probably the main things that I would obtain for the workup beforehand that maybe haven't been already achieved.
That's wonderful. So you read my mind. So optic fundoscopy, no papilledema, which is not uncommon in the setting of an active leak. In labs, unfortunately, was unable to get enough specimen for a beta-2 transferrin, which is always frustrating. Moving on to treatment options, Dr. Ray, could you comment on what would be your next step? Do you go right to surgery? Are you thinking about medical management, adjunctive management? How do you approach these patients?
Yeah, I'm old enough that when I was finishing my fellowship, we still were sort of learning about what the underlying cause of these leaks was, and we knew when you went to hear people talk about spontaneous CSF leaks, we knew that they had the highest rate of failure, that they were the most likely to have a second source of a CSF leak, or when you would repair these and they'd get another source. And so when I was at Hopkins, we had a great neurology division, the hydrocephalus division at Hopkins. And my partner, Gary Gallia, and I, who's the neurosurgeon I worked with, started monitoring these people. And so we published a bunch of papers back that sort of found that these patients had elevated ICP, which I think people were understanding. But the way I think about spontaneous CSF leaks is that it's a symptom, it's not the cause. And so you have to manage the underlying etiology of the leak. Years of doing this at Hopkins, and I still do it in private practice, but my approach has to be a little bit different because I'm not at a major academic center anymore. But I will always get these patients. I don't look at this as a surgical emergency. I'll let them know that if they have headaches or fevers, they need to be on antibiotics and call me right away, and that they are at increased risk for meningitis. But I will get them seen by a neurologist, and I will manage the underlying etiology and try to manage their CSF pressures prior to repairing them. I feel that's really important because if you don't, I worry that my repair is going to fail. So to me, the most important thing is getting them in line with a neurologist that can treat their hydrocephalus or their increase in cranial pressure.
That's great. And I Absolutely. Want to come back to and ask you some questions about or get some more insights on the difference between approach in a private skull-based setting versus an academic skull-based setting, because I think probably there are some subtleties. So just kind of briefly want to touch on some of the different options for treatment, and then we'll go right back to the panel and talk about that some more. So this table is from a study that we had published several years ago, just looking at different interventions for idiopathic intracranial hypertension associated with CSF leak, basically with the idea being that there's sort of a comprehensive management that needs to happen, rather than just seeing have leak, need to fix, and then move on. So weight loss obviously is a major component of that. Diet and exercise can be helpful. There's data from decades ago that actually shows that bariatric surgery can be helpful, but obviously is a very significant intervention. Since we published this study, I would add GLP-1 agonists to this list. GLP-1 agonists, not in addition to having really great outcomes with weight loss, it can also directly decrease the production of CSF at the choroid plexus. So they're working actually in two different levels, almost like a better tolerated acetazolamide in some ways. Obviously, carbonic anhydrase inhibitors like acetazolamide, also topiramate, are critical. One point I always make to patients about the acetazolamide, though, is that the doses required for control of idiopathic intracranial hypertension in many of the studies that were done in the ophthalmology literature are very high, and they can be very hard to tolerate. And then one thing I'd love to get you guys to weigh on too is the use of sort of adjunctive surgical options. So when do you consider something like a VP shunt, dural venous sinus stenting? I know that's a controversial issue in the neurosurgical world, getting our ophthalmology colleagues involved for nerve sheath fenestration, and then also managing comorbidities. So let's maybe we'll start with Dr. Illing for that first one, and then go back to Dr. Ray to get some of the nuances of private versus academic world. Dr. Illing, when do you consider some of these adjunctive treatments?
Yeah, we have this discussion usually preoperatively with the patient just to give them education about the disease pathology. Like Dr. Ray said, this is a disease that's caused by something else, and that's usually that idiopathic intracranial hypertension. So it can be a delicate discussion. You know, many people are sensitive about their weight. Not everyone is morbidly obese, but a good majority of patients are. We also see a good amount of patients that are non-compliant with things like their CPAP machines. So there's discussions about, hey, we need to really be serious about this therapy, because this could have led to this problem. So I think there's just, when I see these patients coming in, I just know I'm going to spend extra time with education and discussion about options, and letting them know that there's more than just a surgical treatment for this. There's going to be more involved. And that means more doctor's appointments, follow-up medications, possibly other surgical procedures, consultations about weight loss or with sleep medicine. So really preparing them for what's ahead, but telling them and giving them hope that it's treatable and we can partner with them. Because I think what gives patients the most amount of stress is the thought of the brain fluid leak, is, you know, in this patient's case, the meningitis, which can be life-threatening. Those kind of things really scare them. So they are engaged and ready to partner with you in their treatment. I do think we discuss all options. Some patients are very averse, understandably, to more surgical interventions, including VP shunts. I do find our neurosurgeons are not super eager to use that either, because of the amount of ER visits from headaches that happen after shunt placement. It can be a burden on the system. The dural venous sinus stenting, I think it depends on the neurosurgeon and the patient, because that does commit them to using some anticoagulation for at least a 6-month period after placement, and some frequent checks and MRIs to surveillance those stents. And there's also a question of how long they would really get pressure reduction from that. I think that's still truth to be told for that. So a majority of my patients choose the acetazolamide. I do try to partner with a neurologist. It's not a medicine I want to manage long term, but I am happy to start that while they're in the hospital. For most of the patients with their surgical intervention, I will place the lumbar drain at the time of their surgery and try to glean some measurements from that, both when they're leaking before my repair during the surgery, and then after, once their leak site is closed, to tell what their pressure may truly be outside of the hospital and when they're not leaking. And then we try to dose appropriately their acetazolamide and make sure they're tolerating the side effects in the hospital. Otherwise, we have that discussion with the neurosurgical team about these adjunct options. But I'd say majority of patients are most willing and able to, in the immediate post-op period, pursue the carbonic anhydrase inhibitors in my practice.
And Dr. Ray, would I guess one question, of course, that we touched upon is do you manage these any differently now that you're in a private setting versus the academic setting? And then number two, something that we struggled with this patient is when you have 3, 4, 5 potential sites of leaking, what do you go after?
Yeah, those are great questions. So obviously, when I was at Hopkins, we would actually put in a drain and monitor these patients for 3 to 5 days, and they were part of a study that we were doing. So we would look at their pressures and monitor them afterwards. But I don't have we sort of after the study stopped putting the drain in for so long. But I practice at a community hospital, but I still repair these leaks, and so I will still make sure that they see a neurologist, and usually I send them to the hydrocephalus center, and I still know the people over there, so I can get them seen. But almost always these patients are on acetazolamide before I repair the leak, because their pressures are going to go up when you repair the leak, right? We know that. And in terms of the other thing I focus on is their obstructive sleep apnea. I think we know that contributes. So they need to understand, if they haven't had an evaluation with a sleep study, I'll make sure that they get a sleep study, and we get them arranged. It was always a tricky thing with my neurosurgical colleagues when we could start them on their CPAP after the repair, because you want to make sure you don't disrupt the repair. So that's always a tricky thing. I think in the end we sort of settled out at about a month. But these patients typically will be on Diamox. We'll manage their obstructive sleep apnea, but I won't repair a leak for a spontaneous CSF leak. I won't try to repair these leaks until they've seen a neurologist that feels comfortable. And that's the important part of this is I'm in a community hospital. So if I send them to a general neurologist, I may not feel comfortable that they're getting the full workup. A general community neurologist may not see as many of these, so they may not be as comfortable treating it. So I make sure that the neurologist that sees them is comfortable managing this. So the bottom line is that I make sure that everything is managed before my repair, so that I give them and me the best success in getting my repair to be successful. And in terms of the drain, I just leave the drain in overnight and then pull it in the morning.
So we struggled with this one a little bit because there are so many potential sources of leak. Ultimately, discussing with the patient, we initially tried medical management. Unfortunately, couldn't tolerate acetazolamide or topiramate. This was really sort of on the cusp of GLP-1 agonists, so that wasn't an option at the time. Through diet and exercise, unfortunately, minimal weight loss was achieved. Continued to have headaches, continued to have watery rhinorrhea. Ultimately discussed at a multidisciplinary skull-based conference, decided, and the patient was interested in proceeding with surgical intervention. And again, I guess one of the advantages to being in the academic center is you can sort of bring all hands in at the same time. So we actually did a combined approach. We did lumbar drain with intrathecal fluorescein to help identify which of these sites were actually potentially leaking. Not every encephalocele leaks. And then you can get into a conversation about, should we need to, surgically address something that's not leaking? Probably not in a situation like that. She underwent an endoscopic transnasal approach to the ethmoid and frontal ethmoidal leaks. The supraorbital leak encephalocele we felt would be difficult to reach from an endoscopic approach. So I actually combined that with a right frontal craniotomy and a pericranial flap. And then also with my neurotology colleagues, underwent a left temporal craniotomy for repair of the middle fossa. So very aggressive surgery, obviously not the typical thing that you do for your typical CSF leak, but she was motivated to try and be as definitive as possible. Intraoperatively, did find multiple encephaloceles that did have evidence of active leaking that were repaired. And so I guess one thing before we go on to the next slide, I would throw back to the panel. Maybe we'll start with we'll go back to Dr. Illing. What is your take on this for surgery? Where would you have, obviously hindsight's 2020, but which would you attack? Which would you stage these procedures? Would you do them all at the same time?
Yeah, no, I mean, for the patient, I'm sure it's wonderful to have one anesthesia and when possible. I think functionally with all of the different subspecialists you involved with your neurotology and your neurosurgeon, I think it just depends on timing. Sometimes that might delay your surgery so far out that the patient would rather stage it. I'd say that due to some scheduling issues, we often stage hours here between patients that have different CSF leaks in the lateral area and the anterior area. But I think that if it's possible to do it at the same time does make sense for the patient standpoint if achievable. But I don't think there's a problem if you do have to stage it, particularly if you're, patients may be leaking, like you mentioned, from one side and not another. And so you may see how they do if you address the leaking site first. Obviously, that would take precedence. But then if these other sites aren't actively leaking, those are things that if you manage the pressure, you can probably monitor.
Dr. Ray, any thoughts on that? Yeah, I mean, I agree. I will, and thanks for bringing up the fluorescein, because I would not try to repair these leaks without using fluorescein, because they may have multiple leaks, and you want to really carefully look at the MRI scan to identify different potential leaks, and then carefully examine these areas. I will repair anything that's actively leaking, but I'll typically leave alone something that's not leaking. Kind of another interesting anecdote is that sometimes when you put them on acetazolamide before the surgery, they stop leaking. So you kind of want to know what the likely source is, and I'll repair the likely source. But the bottom line is I'll repair what's leaking and leave what's not. Obviously, I inform the patient that there's always a possibility that they may have a new area of leaking down the road, but once you get the intracranial hypertension under control, these patients tend to not leak anymore. So again, treating the underlying cause, I think, is the most important takeaway for these patients, and then obviously doing a good repair and repairing the areas that are actively leaking.
One thing I've struggled with is, how do you counsel patients who ask, okay, I had a leak, I started acetazolamide, I don't have an obvious leak anymore, but I do have encephaloceles, I do potentially have a dural defect, perhaps it's scarred over, perhaps not. What's my risk of meningitis going forward if I don't do anything surgically? Dr. Illing, thoughts on that one?
Yeah, I think that's difficult to know whether their risk is increased over the general population or not. Ostensibly, if they're not leaking, there's not, necessarily an open communication, but that can be really tricky, especially in the nose where there's other sources of drainage. So I tend to tread lightly there and think that the risk of meningitis is real. And I haven't seen any studies that definitively say for these unaddressed medically managed leaks what that risk may be long term, especially in the younger patients that we tend to see these in. Middle-aged females are a big source of my patient population. That it makes me nervous years down the line would they be vulnerable. Often I think that the risk of the rate of meningitis isn't as high as I would expect for someone with a leaky site, because it's almost like a one-way valve that's just going out and not letting things ascend into the brain. But with time, if they do have changes, you wonder if that will change, if there is a area that's weak, that they might be vulnerable at that spot. So we have a delicate conversation, and in general, in the nose, I do tend to encourage, if there's suspicion for a leak and it's difficult to monitor with collection of beta-2 transferrin or other imaging modalities not being extremely specific or sensitive, that we do an exploration at least.
Dr. Ray, thoughts on that? How do you counsel patients who maybe do have some improvement with medical management on risks of having an ongoing encephalocele or a site of leak that was not repaired?
Yeah, I mean, I agree 100% with Dr. Illing that it's a careful conversation, it's a delicate conversation, because we don't really have good data that helps us to guide us in managing these patients. And the question is, do you go after every potential encephalocele and every potential area of dehiscence? And again, my approach typically maybe is a little bit more conservative and only repairing the active leaking areas. My feeling generally is that if there's an active leak, that puts them at risk for meningitis. But if there's not an active leak, it's hard to go after and try to repair every area. But you definitely need to make them aware of it. Again, it was their underlying issue that caused these dehiscences and encephaloceles, and managing the underlying issue. I tell them that likely they'll be fine, but that they need to be aware of the symptoms of meningitis, and that they probably have a higher lifetime risk of meningitis than someone that doesn't have intracranial hypertension.
So just in the interest of time moving forward, so this patient ultimately did well. She had a big surgery, but she recovered from it. And I followed her for a while, and then she sort of fell out of follow-up, and 3 years later came back with leaks from the opposite sites. So this time she was leaking from the right ear and the left nose versus the right nose and the left ear 3 years ago. So really just illustrating the problem if the underlying pathophysiology is not reversed. She had tried GLP-1 agonists, was still had a BMI of 47, again, had tried a number of medications, did have a lumbar puncture with an opening pressure of 23, which is probably elevated given that she's leaking, and that illustrates that she has ongoing issues. After discussion with our neuroradiologist, we opted to do a CT cisternogram, which again was suspicious for leaking from a number of different sites, both the left cribriform, here you can see the evidence of the prior repair of the tegmen over the left mastoid, with some fluid in the mastoid below that, and then fluid in the right mastoid as well. So in the couple of minutes I have left, Dr. Ray, maybe I'll go with you, because we have one question from the audience that also to touch on. What is your step? What's your plan now? So she's, do you consider additional surgeries again? Do you go for one of those adjunctive treatments, such as a VP shunt? That's question number one. And question number two was, what do you do in the community if you don't have a neurosurgeon that is interested in doing these or trained in doing these type of endoscopic skull-based cases? Do you still do them?
Yeah, so I'll answer the second one first. I still repair these endoscopically, unless it's a huge defect that I think requires craniotomy, and then I'll send them to Hopkins. I will still repair these leaks. I started repairing these leaks at Hopkins even before I started working, when we were first developing the skull-based practice. And so I did a bunch of these repairs before I worked with a neurosurgeon, and I'll do these repairs, continue to do these repairs in practice. I feel that we can do these, we can repair them from below and do a good job without necessarily the help of our neurosurgical colleagues. Unless it's judgment, right? You just want to make sure that if it's if you have experience in repairing these, you know the leaks that you're probably not going to be successful with, and you probably need help with the neurosurgeon. This is a classic academic center problem, right? I mean, this is as difficult a case as you can deal with. I would definitely send this case to you, Ted, so you can manage her. But that would be my plan.
I'd call and ask you what to do about it.
But my answer would be, she's failed every conservative option. So she needs something done to manage her intracranial hypertension. So it's probably going to have to be an adjuvant option at that point to manage her intracranial hypertension. Otherwise, she's going to continue to develop these encephaloceles as she has, and then you're going to have to repair the new areas of leaking. So if I were managing her, I would repair the leaks and then be more aggressive about saying that she needs another adjuvant option, likely a shunt, to get her intracranial hypertension under control, or she's going to continue to fail.
Yeah. Well, unfortunately, we're out of time, because I know that we could just continue to talk this over. And ultimately, I will just say that that's the approach we took except that the patient understandably is reluctant to undergo further surgeries. So we're going to try medical management in the VP shunt first, or I should say skull base surgeries, and then just very closely observe to see if she continues to leak. But we're a little bit behind, so I want to thank Dr. Illing, Dr. Ray for really just excellent panel and for your great insights into these difficult situations. And I know that we all learned a lot from it. So thank you both very much.
Thanks for having us, Ted.
Thank you.
All right, so I'm going to move on now into the parts are mislabeled, but this is actually part 2 of the skull base discussion. And I want to introduce our faculty. First, we have Professor Dr. Christian Betz, who's chair and head of the Department of Otorhinolaryngology in Hamburg, Germany, and Dr. Ivan El-Sayed, professor of clinical otolaryngology and director of the Minimally Invasive Skull Base Center at UCSF. So a couple of really true experts in the field. So hopefully we'll get a lot of insights today. So this talk will be about emerging options for locally advanced sinonasal malignancy. I want to start quickly with a case presentation, and then again, try and get right into the panel discussion, which I think the meat of this will be. So just briefly, this is a 66-year-old gentleman with no significant medical history. He is a smoker, half pack per day, presented with 2 weeks of left eye pain and some vertical diplopia. With discussion, it sounds like he'd been treated for presumed sinusitis with bloody rhinorrhea on the left for at least a month or two before that. On exam, he had swelling of the left medial canthus. The left eye is laterally displaced and mildly proptotic, and he has diplopia elicited on his limited vertical upgaze. Importantly, his visual acuity was grossly intact on both sides. And on an intranasal exam, he had a fleshy polypoid mass. So initial imaging, CT and MRI showed a irregular mass of the left frontal ethmoid and nasal cavity region extending to the right frontal. There's erosion of the posterior table of the left frontal sinus and anterior cribriform plate with some intracranial involvement. There's considerable extension into the left medial orbital cavity, abutting the medial rectus and superior oblique muscles. And then also there is involvement of the subcutaneous tissues right in that area of the medial canthus. Initial workup and staging included a biopsy which showed P16 equivocal squamous cell carcinoma. He did have a PET scan which showed this left lung lesion, which we did a core biopsy. Unfortunately, it was non-neoplastic. So we staged this as a T4, probably T4A, N0M0 squamous cell carcinoma with significant orbital extension. So going right to the panel, Dr. Betz, I'll start with you just because you're first on my slide. What additional workup would you want for a patient like this, and what discussion would you have with them regarding treatment options and preferred modalities?
Yeah, thanks a lot for this great case, and thanks a lot for having me in this discussion. There's a few questions I would like to ask in addition. One is the PET CT shows some FDG avidity in the lung, but that proved to be non-neoplastic. On a core needle biopsy, I thought maybe in my department they would do a complete excision because what else could it be than either a primary lung or a tumor or a metastasis that lights up so brightly. I would probably test for HPV DNA as well, not because it would change my direction in therapy, but because it probably has some implication for the prognosis of the patient. With regards to how I would approach the patient, obviously we would discuss in the MDT, the multidisciplinary meeting, and we would probably offer, because of the extent of the tumor, we would probably offer as primary suggestion an induction chemotherapy, followed by definitive treatment, depending on how the tumor reacts on the induction. But we would probably offer other possibilities for the patient if he doesn't want to go along with this, such as primary definitive chemoradiation, or instead surgery followed by radiation or chemoradiation.
Yeah, I would just quickly add that we too were surprised that that lesion was non-neoplastic, and it was several biopsy specimens were obtained, and we actually re-reviewed them with surprise. I think with regards to resection, that would be the more definitive modality for diagnosing the lung lesion. I think with this particular patient and the realities of scheduling, it just becomes, we didn't want to delay the care more, trying to have that procedure performed before getting treatment for his primary tumor, which was causing a lot of symptoms. Dr. El-Sayed, anything to add to that before we move on?
Yeah, no, actually, I think that's interesting. I mean, obviously, we present this at Tumor Conference and review the imaging. Have to really review it with our neuroradiologist here at UCSF, because they're the skilled ones that see, a number of these cases. And first of all, to review the primary tumor, the question of the PET-CT, I hadn't actually thought about resecting it primarily, and I think mainly would be the level of suspicion of our radiologist, whether or not this is actually something real or not. And I think the issue with delay, at least at our institution, would be a real issue. I don't think we could get that done and then get to the treatment of the primary tumor. So we would watch that closely afterwards. I think that the issues of treating the primary are very real. The impact on the orbit, potential, you have an eye here that you can potentially save, and you don't want to, miss that opportunity while we're kind of trying to pursue something. But I have to acknowledge that that lung lesion may turn out to be something at the end of the day. The other issue brought up, P16, I believe that P16 in the nasal cavity is actually not a good marker. You have to test directly for the virus and DNA, and some other tumors like adenomyocystic can produce P16, but not HPV related. So it's not a specific indicator in the nasal cavity. I did a little study years ago looking at the clinical importance of diplopia and whether or not they actually had restriction of gaze as an indicator of if there's actually rectus involvement or muscle involvement of the tumor. I don't know how accurate it is, but it's very difficult to determine on MRI. But we would get a very high resolution MR, usually with the T2, and look for actual invasion into the muscle, maybe evidence of edema into the muscle or something like that. But this clearly has a significant amount of tumor invasion into the orbit. It kind of tracks up superiorly there into the superior orbit. It's not just a limited entrance into the eye. So I think that with that involved, I would start thinking about induction chemotherapy. The role of induction in my mind is if you can change the surgery or limit morbidity that the patient would incur. And there's certain types of pathologies that you would look at where you might actually not need surgery if they have a really excellent response. So I don't know if you're going to talk about that a little more. I don't want to jump the gun here, but we would definitely—
Good foreshadowing.
Yeah, we would definitely, this is a patient I would be thinking about induction chemotherapy in discussion with the patient. The other point I would make is if this workup was not done at our institution, I would have all the pathology clearly reviewed at our institution. Sometimes they'll restain and they'll just, they'll look for P16 markers and the HPV RNA because the accuracy at institutions that have less experience, at least in the US, can be very low. Sometimes I think Anderson looked, and some of these studies are out there where they'll change the diagnosis 20 to 40% of the time, or at least have some significant impact. So you want to make sure that it's a skilled pathologist who sees these types of tumors frequently that's reviewing this. And if you're not at an institution where they have it, I would really think about sending it out to a major institution, just letting them review it, because it makes all the difference in the world. You could be treating, the wrong tumor at a certain point.
So that was exactly our thought process as well. With an organ preservation strategy with regard to that left orbit, we elected to proceed with induction chemotherapy. Just a couple of very brief words on induction chemotherapy, because again, I want to get this back to the panel as quickly as possible. Specifically with regard to squamous cell carcinoma, as most audience members probably know, this is the most common of sinonasal malignancies. About a third are HPV related, which does have prognostic implications with sinonasal squamous cell carcinoma. We still have a long way to go in terms of survivals, and this is still a highly morbid and potentially mortal disease. Often these are locally advanced at presentation, as we see with this patient, and traditionally the gold standard is margin negative resection followed by adjuvant therapy. However, as this case illustrates, that can be a very morbid undertaking and really need to weigh with the patient whether that is worth it up front versus other options. So we proceeded with induction chemotherapy. Just briefly, induction chemotherapy. Initially, the data were extrapolated from laryngeal squamous cell carcinoma. There's been some good studies that have started to look at its role in sinonasal squamous cell carcinoma. A study from 2021 is one that's often quoted. Looked at 123 patients, about 90% of them were T4 tumors. About 57% responded to induction chemotherapy, including a platinum agent. And the frequently quoted statistics from this are number one, that induction chemotherapy responders overall were noted to have improved survival. So it's a kind of a prognostic implicator. Number two, with regards to squamous cell carcinoma, at least, there was no difference in subgroup outcomes versus when proceeding with surgery versus chemoradiation after induction chemotherapy. And probably most notable for this patient, 67% of the patients in the study had orbital invasion, but only 18.5% required exoneration, which has been used as evidence basically that this can be an organ preserving strategy. There have been some small studies that have suggested there may be an improvement in in overall survival, but that is really still to be figured out. So this patient just quickly underwent induction chemotherapy. We planned for 3 cycles of triple agent, including cisplatin. Unfortunately, the patient developed influenza, which delayed the second cycle. And after the second cycle, the eye was actually clinically worsening. So we elected to re-image at that point, detected a mixed radiographic response, but unfortunately progression of the orbital disease, which is quite notable, especially on the MRI, with the tumor really abutting the optic nerve. So coming back to the panel, and Dr. El-Sayed, we'll start with you this time. Now that we have this patient that has gone through 2 rounds of induction chemotherapy and has had a mixed or poor response, what is your next step?
That's great. So first, actually, I should mention, by the way, that the ECOG trial on induction chemotherapy was just accepted yesterday for publication. And I think I'm allowed to talk about the results. It did show that they were able to improve orbit sparing or organ sparing, but not survival. But it's a very low number of patients. That question is still out there. The second thing I point out about induction chemotherapy is that sometimes you'll see a great response in the sinonasal cavity in the orbit, but not in the brain. And that's because the tumor sometimes has a problem passing the blood-brain barrier. And so some of the tumors will see this, especially on the neuroendocrine side. So this patient's had 2 rounds of induction chemotherapy and not responding. And the other thing we haven't talked about here is immunotherapy, which we're not really working in. So one interesting effect that you might see with immunotherapy is they get such a reaction that sometimes you actually see increase edema and swelling. And then you're wondering, is that a real non-response or not? And so for some of these other tumors, this comes up. But for induction chemo, you should start to see the tumor shrinking and decreasing in size. And after 2 responses, if you're not really seeing anything, you've labeled this a non-responding tumor. And at that point, you go back to plan A. So when I first started doing this in 2002, the treatment for sinonasal cancer for almost every tumor was surgery followed by radiation therapy. And we now know that that's a very different scenario. It depends on the biology, the pathology, and all that. Yeah, this patient would need to go to the OR, and the timing of that you have to think about as well. You need to wait for the chemotherapy to wear off, so you need a few weeks of resolution, let the blood counts recover, and that usually gives you time to get the neurosurgeon in order and the rest of the team. And so this patient here would get a cranial facial resection. There's extensive orbit invasion. I don't think at this point you can save the eye, but there's really too much gross invasion, and that's a whole discussion in itself about when you can and can't save the eye. But if you're going to cut close margins, you need to rely on radiation and chemotherapy to kind of clean that up, and you already know you don't have that as a response. So this patient will have an orbital generation. The tumor is very anterior, so the posterior frontal sinus wall, the anterior skull base, and I believe there was some skin invasion as well, or entrance into the skin. So you might even need to resect skin. That could impact whether or not you have a pericranial flap available to close the skull base. So I think, as you indicate there, you need a microvascular flap. In this setting, we'd probably use an ALT flap at this point. And so you have to have now 3 surgeons involved in this case, and a very long chunk of OR time. And then I think post-operatively, you go back to radiation. And it's a question whether or not you use chemotherapy, since you've already labeled this unresponsive to chemotherapy.
Yeah, and I'm sorry, go ahead.
Oh no, so I'll stop there. I usually will bounce that back to the medical oncologist. I'm sorry. One other thing I didn't mention is that at this point, we would also do genetic testing on the cancer, and so we have our own panel, the UCSF 500. There's some commercially available panels as well, and other institutions have their own. But obviously, we're looking for markers of responsiveness, and especially for immunotherapy at this point.
Dr. Betts, anything that you would add to that approach?
I think Dr. El-Sayed has extensively answered all the questions that came to my mind, at least. I would probably consider doing a restaging, full body restaging before the operation, just to make sure that there's no distant metastasis, because he didn't react at all on the induction. Apart from that, Dr. El-Sayed mentioned the immunotherapy. I mean, we're looking at the Keynote 689 study coming out in 2 weeks, using transferring immunotherapy into primary head and neck cancer treatment, most likely at the end of this year. And maybe we could also extrapolate these results onto sinonasal squamous cell carcinomas and give immunotherapy in advance before as an induction instead of chemotherapy in the near future. But that's not for discussion at the moment. But probably later this year it will be.
I'm moving on, and for the sake of time, but I selfishly wish that this panel were about 2 hours long, because I'm learning a ton just by listening myself. So broadening out, there was some comment earlier on. I think Dr. El-Sayed talked about other sinonasal malignancies. Obviously, SNUC, sinonasal undifferentiated carcinoma, is another aggressive sinonasal tumor where we have decent data to use induction chemotherapy, and not only as a therapeutic agent, but also as sort of a guide in determining appropriate further treatment. So the study from 2019 looked at 95 patients with SNUC treated with induction chemotherapy. One of the major findings was that responders had an overall much improved survival. So if their tumor was sensitive to chemotherapy, they just did better overall. For those who did not respond, they did, but proceeded to chemoradiation as definitive treatment. They had essentially 0% survival versus 39% in this study for surgery. So this really has influenced certainly our tumor board practice to use induction chemotherapy with SNUC as a fork in the road to try and determine what the best next treatment is in terms of surgery versus chemoradiation. Just very briefly, induction chemotherapy for other sinonasal cancers. This is a rapidly developing field, and I'm going to ask your take on this in just a second. But this is from a review several years ago. Essentially, there's data that support the use in squamous cell carcinoma, SNUC, certain olfactory neuroblastomas, probably not so much adenoid cystic carcinoma, adenocarcinoma. But there's a lot to be figured out. There's no consensus on the regimen, and the side effects can be significant. So I guess before we move on, Dr. Betts, I'll start with you this time. Would you agree with these conclusions from this study several years ago, or do you think that your approach to the use of induction chemotherapy has changed at all with recent data coming out?
The thing is, the studies that we have on induction chemotherapy, they are not really controlled trials. They are all case series, and it's a mixed bag of entities that are treated in there. It's mostly larger tumors, but especially the data from MD Anderson, they even used a lot of different induction chemotherapy agents, obviously for the different entities. So I do think that the conclusions that they draw are valid, but it cannot be used for all tumors of all types. It's just a tendency that we see in these trials or in these case series. But I do go along with most of what is said in there. And in our department, and I think that's true for Germany and Europe, we do follow these recommendations that we've just discussed, and we try to do organ preservation measures by using induction chemotherapy, even though when I started out being trained, I was always told, if you do induction chemotherapy and then you follow by surgery, you still need to resect in the old margins, which we don't do nowadays. If we do organ sparing of the orbit, for example, we do obviously resect in the new margins, not the old margins, and that's contradictory to what I was trained in, at least. And I don't think there's enough objective data out yet supporting this new margin treatment. And I think that's the main hindrance of this treatment regimen. But I think as we go along, we will probably get more data out in the next years that we can rely on with regards to induction chemotherapy followed by definitive treatment.
So I can't believe we're running short of time already, but we also foreshadowed a little bit about talking about future directions, immunotherapy, role perhaps of checkpoint inhibitors, PD-1, PD-L1 inhibitors. I wanted to get your broad take on what you think is on the horizon, what your studies perhaps that you're looking forward to, or where you think this may go in the next few years, specifically with regard to immunotherapy or checkpoint inhibitors, but really just in general, whatever insights that you have. I've listed here, and in the next slide, you can see obviously this is from a study from 2022. We're not going to go through this in detail. This is just to say that there are many potential mutations in molecular or sites that can be targeted therapeutically, either for induction therapy or therapy down the line. Are there any of these that you would like to highlight, or where do you see the future going? And Dr. Saeed, I'll open that to you.
Okay, yeah, perfect. First off, I'm gotta throw in a quick comment about induction chemo. The point I would make is that if you think it's going to change the surgery, I would definitely rely heavily on it. It's very nuanced. There's some tumors like neuroendocrine tumor where we definitely go with induction chemo, and if you have a great response, you're just going to go straight to chemoradiation. And that question about how much surgery do you afterwards is an excellent one. We've removed several tumors and found no tumor in the specimen. So it's really interesting. In terms of where I think we're going next, I think the next incremental step is going to be mixing the immune checkpoint inhibitors with chemotherapy in the induction protocols. And the idea is that we don't have a improvement in survival, we just have organ preservation. So now we're trying to see if we can actually bump the numbers up and improve survival. The other question, I was just at an Asian conference yesterday looking at intraarterial chemotherapy, and there's still a lot of data coming out of Japan that's indicating that what we see for some are, maxillary sinus and ethmoid sinus squames, 50-60%, 5-year survivals. They're reporting 89-90% 5-year survival. Again, very selected data. There might be some increase in complication rates, and a lot of that has to be sorted out, even the genetics of the tumors they're treating. I think what you're going to see is a tumor that is guided by the molecular biology. Do HPV responsive tumors, have the same outcomes, or is it similar to tonsil cancer, where they actually have a better outcome? But in terms of each molecular marker, I'm just going to say there's really a whole lot of targets. We only have a few bullets right now, so I think we need to develop, more specific, therapies. But I'm going to step out and let our other panelists weigh in real quick.
Yeah, Professor Betts, any last insights for us before we turn it over to the next panel?
Yeah, thanks a lot. I agree with everything Dr. El-Sayed said. I'm not a medical oncologist. I'm mostly a surgeon. So I think the biggest insight will come from the medical oncology that helps us in the interdisciplinary treatment of these diseases. But obviously, the individualized treatment regimen for patients will increase, and we'll have more options both in recurrent metastatic phase of a tumor, but also in primary tumor treatment with curative options. And I do think that immunotherapy will play a role. I do think that we will have immunotherapeutic options soon for primary tumor treatment of the head and neck area, including the paranasal sinuses, at least for squamous cell carcinoma, which make up more than 50%. So I do think we are getting towards a more individualized and probably better treatment for our patients in the near future. It's probably very costly. That's something that needs to be realized as well. But at the same time, most of our patients will benefit in the long run with head and neck cancers altogether, and with sinonasal cancers in particular.
Well, I really appreciate your insights, Professor Betts, Dr. El-Sayed. That was wonderful. Unfortunately, I've run over. It seems like we just started. So we're going to move along now. There'll be a break. We'll start back up at 11:05 with Dr. Ed Kwan leading the next set of panels on topics for the comprehensive otolaryngologist. And again, thank you to all the panelists and for participating today. We really learned a lot.
All right, thank you for having me.
Thank you. Bye.
We shape the future. We continue to care for the well-being of patients, and we treat everyone with respect. We are trustful, accountable, and we continuously strive for improvement. We encourage strong and thoughtful decisions, and we care about our environment. We are a 100% family-owned business with technological expertise ranging from optics, mechanics, electronics to software. We are a recognized solution provider for endoscopy, delivering customer-centric added value. We leverage comprehensive data and streamlined processes to drive our business. We are Karl Storz. And we empower individuals to become engaged employees. This is why we all come to work every day. And this is why all our customers trust our solutions every day. Because we're leading to solve core customer needs. Because we're offering a unique portfolio. because we're acting as a trusted advisor. And because Karl Storz is living our commitment to reliability, quality, and availability all the time. We shape the future. We continue to care for the well-being of patients, and we treat everyone with respect. We are trustful, accountable, and we continuously strive for improvement. We encourage strong and thoughtful decisions, and we care about our environment. We are a 100% family-owned business with technological expertise ranging from optics, mechanics, electronics to software. We are a recognized solution provider for endoscopy, delivering customer-centric added value. We leverage comprehensive data and streamlined processes to drive our business. We are Karl Storz. And we empower individuals to become engaged employees. This is why we all come to work every day. And this is why all our customers trust our solutions every day. Because we're leading to solve core customer needs. Because we're offering a unique portfolio. Because we're acting as a trusted advisor. And because Karl Storz is living our commitment to reliability, quality, and availability all the time. With our values, our vision, and our value proposition, we shape the future. We shape our future.
Surgeons rely on technology to achieve their primary goal: positive patient outcomes. OR technology advances rapidly, so surgeons need one solution that can keep pace to remain state-of-the-art. One scalable video system evolves with advancements in technology. A modular design philosophy with software enhancements that adapt to changing physician techniques, serving multiple surgical specialties. Image 1S provides surgeons with exceptional visible data. Software enables 3 NIR ICG visualization modes to meet procedural needs. Surgeons can choose between fluorescence settings to assess perfusion and visualize critical anatomy, all designed to improve overall outcomes. NIR ICG visualization is now possible in 4K 3D. Restored depth perception enables precision, resulting in reduced operative time and errors. Plus, AI-enabled software for digital horizon control to keep orientation throughout surgery. Exoscopes, enabling ergonomic open procedures, can be easily incorporated. Choose between fiber, digital, and single-use flexible video scopes, all within one system. Your patient, your choice. Image 1S offers one scalable modular method to deliver data that creates pristine imaging, meeting the specific needs for every minimally invasive surgical application. Realize the value of one to reduce your surgical video costs and buy what you need when you need it. Let us show you what's next in visualization data and information acquisition for today and tomorrow.
All right. Hello, everybody. Welcome back. So we are going to proceed to our second portion of Virtual Rhinology 8. Thank you very much for all of you for joining us all around the world. So these are going to focus on topics for the comprehensive otolaryngologist, but of course also have a very large component that applies to rhinology in general. So the first topic that we're going to cover today is on chronic rhinitis, new options for an old problem. And we're going to be talking about how this problem has largely been big part of what we've been treating for our patients lately, but there have been some interesting new developments that can help us further guide therapies and be more effective, potentially more longstanding, but also want to hear from some experts in terms of how they think about this topic. So this is the first part. We have myself from the University of California, Irvine. My name is Ed Kwan. I'm very honored to be joined by Dr. Ben Bleier from Massachusetts Eye and Ear Infirmary and Harvard Medical School, and then Dr. Lauren Rowland from Washington University in St. Louis, who are going to be my esteemed panelists for this component of the talk. Welcome, Ben, and welcome, Lauren.
Thanks.
So the first, thank you. So we want to start out just with a little bit of background. When we talk about the term chronic rhinitis, it's a very, very broad term. We've largely thought about rhinitis symptoms that can last for longer than a period of time, several weeks to several months. And then there's a lot of different ways we can break this down. You can see from the ICAR AR article from 2023, there certainly is a pretty strong way to potentially just break it down into specific etiologies, specific triggers, pathophysiology, and there's a lot to be understood. So a lot of what we're going to try to focus on today is largely going to be on this last column here, which is vasomotor and neurogenic rhinitis. We're talking about watery rhinorrhea and runny nose, because I think this is where most of the recent procedural interventions and the basis of disease has been developed. So without further ado, I want to just really dive into all the possible ways that we think about this condition. So I'm going to start with you, Dr. Bleier. How do you usually make the diagnosis when a patient comes in to see you of chronic rhinitis? What do you ask about, and how do you determine that's what the condition you're planning to treat is?
Yeah, thanks, Ed. So I think, in some respects, this is a diagnosis of exclusion, because when your typical patient comes in, you're having an expansive potential diagnosis in your differential for inflammatory causes, infectious causes of congestion and drainage. And so you're doing a very similar workup that you would do for chronic rhinosinusitis. And that would involve obviously taking the history, performing a nasal endoscopy, and potentially supplementing that with imaging. Typically, in patients who we sort of derive this final diagnosis of chronic rhinitis or vasomotor rhinitis or what have you, we often don't see some of the concomitant inflammatory or anatomic pathophysiologic findings that might lead us to these other diagnoses. So oftentimes the story is, I have chronic nasal drainage. It should be bilateral, clear and watery, as you mentioned, but not really associated with other things that we might see within the nose, like polyposis or severe allergic edema and so forth. There are also, typical sort of populations that we see this in, often in older patients, more typically in female patients, but certainly we can see it in males as well. And so once we've sort of excluded some of those other things, that's when we start to hone in on this issue of vasomotor rhinitis. One thing that it's important for me to ask is the character of whether the drainage is anterior or posterior. Because I think there's a lot of overlap in that Venn diagram of postnasal drip and pure vasomotor rhinitis. Sometimes the drainage posteriorly is related to that, but often there are other things that might cause that. And I think LPR is something we always want to have in the back of our mind, because that's going to be much more treatment refractory. And then other sort of more subtle features regarding the drainage is related to things like eating and gustatory rhinitis, and then other activities like exercise, and then certainly environmental triggers like cold air exposure and so forth. So those are the types of things that I'm looking for to hone in on that diagnosis. And I would also make the point that it can be mixed. This can exist in the context of other inflammatory etiologies.
Thank you very much. Very comprehensive overview. What are the cardinal symptoms that you ask about in any rhinitis patient that comes through your clinic, Dr. Rowland? What do you usually want to really hone in on in terms of symptoms? I think you might be muted. So No worries. We'll work out the technical difficulties in a bit. Dr. Bleier mentioned a bit about the character of the rhinorrhea. Dr. Bleier, really quickly, do you also think about nasal congestion as a component of this, or do you mainly focus, especially for this particular condition, the character of the drainage?
Yeah, I think nasal congestion certainly can coexist, but I would say that in the majority of patients, the rhinorrhea is the primary complaint, the primary thing that bothers them. When we start thinking about concomitant nasal congestion, I do want to drive down whether that can be anatomic, so they might have turbinate hypertrophy in addition to whatever's driving the more parasympathetic response. And certainly, if you look at the literature regarding some of the treatment options we'll discuss, the improvements in nasal congestion and some of these other symptoms come along with the treatments of improvement in rhinorrhea. But I do think about it as really a secondary symptom relative to the drainage.
Awesome.
Can you hear me now?
So, all right, Dr. Rowland.
Okay.
So this one's for you. So endoscopy, when you look inside the nose for a patient with chronic rhinitis CZU in clinic, what are you looking for, and what does it tell you when you use endoscopy as a exam finding?
Okay, and sorry, I just missed what Dr. Bleier just said because I was refreshing for this issue. So if I repeat something, I'm sorry. But for endoscopy, I'm looking for sort of rule out other things. So I'm looking for polyps. I'm looking for a sign of infection. As Dr. Bleier said, there's an overlap of people, especially in the Midwest and in certain places where there's allergic rhinitis and a non-allergic rhinitis component. But for allergic rhinitis, I'm expecting more turbinate, inferior turbinate hypertrophy and things like that. So I'm kind of looking to see if that's present. If you had a very obvious, CSF leak, you could maybe see that on endoscopy. So we're ruling that out, or an encephalocele or something really, something that you'd really want to definitely be ruling out.
Great. So we're going to dive a little bit more into medical therapy in the next class of questions, but overarching medical treatment, just kind of a broad bird's eye view. Dr. Rowland, can you speak a little bit about your initial strategy for a patient with chronic rhinitis?
Yeah, so I am still going to start patients on sort of the medical therapy that I recommend across the board, like a nasal steroid. We also use nasal antihistamine sprays that has shown to be beneficial in both allergic rhinitis and non-allergic rhinitis. If I am pretty convinced that this is a vasomotor rhinitis, or there's a component that's non-allergic, then I'll also recommend ipratropium bromide spray. And so that's sort of my medical treatment, that I sort of do different combinations of those sprays based on what the patient's telling me. Because again, in the Midwest for chronic rhinitis, some patients are very convinced they don't have allergies because their symptoms are year round, but it is it's still an allergic component, and there obviously are allergens that we are exposed to year round.
Definitely. And again, that mixed component is very important to always keep in mind. Dr. Bleier, any other additions in regards to overarching medical treatment principles?
No, I think that certainly covers it. Again, I think the order of treatment, whether I start with a nasal steroid versus an ipratropium and then add in a topical antihistamine, kind of depends on where I think the etiology lives and how mixed it is. I will say that with something with a little bit less evidence would be something like topical capsaicin has been used, particularly with the gustatory subpopulations. I don't use it myself, but it has, there is some potential benefit there.
Great. So I'm going to pose two words that are somewhat related, or I should say two symptoms that are somewhat related to this diagnosis. And sometimes patients come in just with this when they come to see us in clinic. What are your thoughts regarding how much chronic rhinitis contributes to each of these symptoms, and how much of a deep dive do you go into for other contributors of postnasal drip and cough? Dr. Rowland, I'll start with you.
Yeah, so at the first visit, I'm still going to treat this as chronic rhinitis could be contributing. I'm still going to, when it's cough or something, if there's anything more concerning about, breathing problems or something like that, then obviously I'll sort of go into those symptoms and make sure that there's no reason to do like a flexible laryngoscopy while they're in clinic. But at the first visit, if there's no red flags or concerns, then I'll treat it as a chronic rhinitis patient and see if they get better. If they do not improve, then I will think about doing the next visit, like a flexible laryngoscopy, to make sure that I'm not missing something else in the airway.
Sounds good. Dr. Bleier, other thoughts about this?
Yeah, so similarly, if I don't see an obvious etiology for postnasal drip and I don't see obvious thick mucus either in the back of the nose, coanus, phenolmetal recess, nasopharynx, and so forth, at that first sort of time point where I'm treating them, be it the first couple, first month and then seeing them back, what I'll often do is just treat them empirically for the rhinitis and have a discussion with the patient that we may not know whether this is contributing to these other symptoms, but we're sort of empirically going to find out if your anti-rhinorrhea improves, but the postnasal drip doesn't. That suggests this is a different medical entity. So I don't think I do such a deep dive unless I see an obvious etiology that might explain some of these other symptoms, because the treatments, both medically and we'll talk about some of the interventional treatments, can be so effective for the anterior rhinorrhea, at least component, and may have some benefit postnasally, that I'm comfortable starting with that and then seeing what resolves and what doesn't.
And I would certainly agree with both of you on that for my own practice as well, especially since the risk profile for a lot of these medical therapies is very safe and they're very easy to use to start. So it gives us a little bit of a screen and information on how to proceed based on the response. Okay, so a little bit more of a deep dive into medical therapy. We did talk a little bit about oral medications. Do any of you use any type of oral antihistamines in the absence of allergic rhinitis workup? I will start with Dr. Roland.
So if I think that there's no allergic component, I don't recommend it. I think if you think there's an allergic component, then the newer generation oral antihistamines would make sense. I have found that many patients are already on these medications. They are more likely to be on an oral medication than a spray because they don't like to use sprays. And so most patients have tried them before. And so you can get some information about if they've had a response already just from your history.
Sounds good. And then we talked about nasal sprays. You guys already are, I think we all pretty much agree on all the things we want to try. So now we're going to look a little bit further into ipratropium, just because we mentioned it multiple times already in terms of the algorithm for potentially treating this watery rhinorrhea, anterior watery rhinorrhea component. So what do you start with in terms of frequency and amount? Dr. Bleier, what is your usual starting dose, and how do you tell patients to take it?
Yeah, so for me, because most of the patients who come to see me have already tried other things, I will typically go right to the 0.06%, and I will typically prescribe it as TID. But I will have a discussion with the patient about several things. The first is that it has about an 8-hour half-life. So we talk about the fact that it may work and that they can determine whether they seem to find it wearing off. So for example, if they use it in the morning and they start to notice that by lunchtime or around then they're starting to get more rhinorrhea, they can add on an additional spray and they can sort of titrate it by themselves. Some patients come in who have been on 0.03% and have not had much of an effect, and I will just rapidly increase to the 0.06%. So the frequency I let the patient decide. But the nice thing about Atrovent, and we have this discussion, is that it really works when you use it. It's not cumulative like our nasal steroid sprays are. So not only is it very effective in that patient, the appropriately selected patient population, but they know almost immediately if it's effective. So we have that sort of benefit of using it both as a therapeutic and as a diagnostic. And so it's one of these medications in our field that works remarkably well when you have the right patient selection.
That's a great point. And Dr. Roland, anything different to add?
Well, I actually start at the low dose, and then I escalate to the higher dose if they feel like it isn't working well enough, and then use sort of that information for counseling of if they should consider a procedure. So I know we're going to get to the procedures, but I know that the evidence is variable, but I sort of use that data to help guide that conversation of if I think there's going to be an improvement from a procedure that would be targeting the same pathway.
Gotcha. You guys, we all think very similar on this topic, so you guys are all way ahead of me in terms of this, but I love it. Side effects. What do you guys counsel patients regarding specific side effects from the medication, if any, or any precautions for these patients taking it? Dr. Rowland, go ahead.
You can have some nasal dryness. You can have epistaxis that's pretty rare from this. I think the side effects are less than, and it's better tolerated than the other sprays that cause more bad taste and epistaxis.
All right. And then I think we know the answer to this one because we've been talking a lot about it. And again, a lot of, sorry, go ahead.
I do think there is, to some extent, some of the systemic side effects, you should consider. So someone with urinary retention or a patient with significant cardiac history, you may want to be a little bit more careful with those prescriptions. So we do want to think about systemic and local, particularly with regards to the, parasympathetic anticholinergic effects.
Yeah, and certainly in some patients with glaucoma, I think there's been some contraindications as well. Thank you for adding that. So this is a paper from Dr. Bleier quite a while ago and forms a lot of the basis of how a lot of these procedural interventions have developed over time. And again, the highest frequency or the highest density of these parasympathetic nerves is in this area adjacent to the sphenopalatine area. And again, we're going to start moving towards the procedural treatments and have the panelists give us a little information on their own experience with them. So we have a bunch of different things, and I may not have listed all of them, but I think broadly speaking, we're looking at direct management of the posterior nasal nerves themselves through lots of different potential modalities. And then we have videoneurectomy, which is the traditional and somewhat we call it nuclear option with this. Looking at this list, the first question, Dr. Bleier, I'll go with you. What do you think are what you use as the indications to ask a patient to consider a procedural treatment for any at any point?
Yeah, so I think a patient who has had a good response to Atrovent, because I really do think that predicts for success with any of these procedures. So a patient who has some response to Atrovent, but maybe doesn't want to use it, maybe is using it 3 or even up to 4 times a day and wants to reduce their reliance on it. So those are the types of patients who I am most optimistic that a treatment would help them. I think as you start to go down the chain, you have patients who you're not really sure whether they've had a response. Again, they have some of this postnasal drip component, and you are kind of hoping that you may gain some additive benefit from a procedure over the spray. And so those are patients where we have a much longer discussion, because in those patients, we really have to counsel them that the data suggests they may not have as much of a response. And at that point, you're starting to balance risks, benefits, procedures that can be done in clinic versus operative procedures. So it's a much more expansive discussion with the patient.
Dr. Rowland, anything different with regards to initial indication?
I agree with the indications. I think the challenge that Dr. Bleier sort of touched on is that the patients who are most interested in a procedure are the ones who have less response to medication, because the ones that have a great response are like, well, I'll just keep doing this. They don't love doing it every day, but the ones who have less of a response are more likely to be a little bit more interested in trying to do something else. And that makes it more challenging to discuss. So.
Absolutely. Very good points. And in your hands, outcomes related to each of the class of procedures. Again, I think we're probably looking more so in the top half in terms of more frequently performed. But what are your thoughts in terms of, how you counsel patients regarding outcomes? In your hands, how are you visualizing that this is helping them down the line? Dr. Rowland, we'll start with you.
Yeah. Of these, what you have on the slide, I don't do videoneurectomy really at all anymore. I most commonly do cryoablation, and that's just sort of what has become most available at our location. So I don't actually know, I'm not saying that it's better than the other 2 options, a radiofrequency ablation or surgical posterior nasal neurectomy. I think those are actually pretty equivalent. But so far, outcomes have been good. And I think part of that is that there's counseling involved and selecting the right patient.
Dr. Bleier, how about in terms of your thoughts for both cryoablation as well as the surgical procedure?
Sure. So I think just to back up, something you have on the slide that's subtle, but I think bears noting, is that you on the top category, you say posterior nasal nerves, plural. And I think that's been one of our sort of advances in our understanding of the distribution of the parasympathetic innervation of the posterior lateral nasal cavity, which is to say, historically, we've talked about the posterior nasal neurectomy as a single nerve that gets lysed, and then you see what the response is. And we see a lot of that literature out of some of the Asian countries, Korea and Japan and so forth. But with the anatomic studies that you showed that I performed back, a decade ago or more, plus subsequent follow-up studies that have been done by folks like John Craig, as well as the Adelaide group, we now know that these nerves are really widely distributed. Even those posterolateral nerves are widely distributed, even beyond the palatine bone. So the expanse of nerve ablation that's performed seems to be important beyond just isolating it to one little area or the area around the sphenopalatine foramen. So from that, what I would say is that when dividing these procedures into two categories of clinic-based procedures versus operative procedures, the clinic procedures have the benefit of, of course, less downtime, less risk because there's no, general anesthetic and so forth. And I think if you look in the literature, the efficacy and outcomes between cryoablation or radiofrequency, you can't really tell a difference between the two. So I think it's just user dependent. They each have some pros and cons, and we can get into that later. But then with regards to moving this into the operative environment, what I would say is you have the benefit, at least in my hands, of really being able to go wide. So you can go much more posterior. You can go much more easily go into the inferior meatus. And again, our data shows that up to 40% of these nerves are actually under the inferior turbinate. So I think ablating that area is important. Now, once you sort of escalate that to a surgical posterior neurectomy, when you say with or without barrier, I think just to clarity for the audience, what that means is putting some sort of interposition graft so after you cut the nerves, they aren't able to reform and re-innervate the mucosa, relatively quickly. And quite frankly, I'm not sure there is much benefit of that procedure beyond the top two. And I think the main difference is that the radiofrequency and cryoablation procedures, they concomitantly injure the mucosa and the goblet cells and the secretory cells within the epithelium in addition to the neurectomy. And then quite frankly, I think that has some additive or synergistic benefit. So I think it's when you think about those procedures, for me, at least, taking a patient to the OR, of course, in a situation where I feel I don't have access to those areas because of a severe deviated septum or large concha bullosa or something, I also think it allows me to do a much more comprehensive and wide-ranging treatment of the mucosa, and I do think that adds some benefit.
Awesome, and thank you very much for sharing those insights as well. For the interest of time, I'm going to actually move on to, because we covered some of those other elements, we're going to move on to the more refractory case. In your experience, these procedures, nerves we know can regenerate, especially these smaller nerves. How long do you guys think treatment effect lasts for in generally any type of these procedures? What's been your experience? Dr. Bleier, I'll start with you on this one.
Yeah, I think if you look in the literature, there's now data to suggest it lasts 2 years and beyond. I would say in my own hands, when I counsel the patients and look at my own outcomes, I hope for about a year to 18 months of benefit. In some patients, it lasts much longer. In some patients, within 6 months, they get symptoms back. So it is variable, but I think if we can get a year of benefit, particularly on the outpatient treatment side, that I would consider a success. And then obviously we get into the whole question of secondary and additional treatments down the road. But I would say about a year is what I've seen in my own hands.
And then Dr. Rowland, just for you, how do you manage the recurrent case? Do you retry medications or do you reoffer a procedure? What's your thought process with this?
Yeah, so I haven't been in practice long enough to have these recurrent cases that are several years out. So at this point, I'm also counseling patients based on the literature that it's about 2 years would be our hope. And then at that point, going back on medications. But if they're interested in another procedure, I would offer it at that time.
Gotcha. Yeah, we looked at this with John Craig, one of my colleagues, and what we found in our series is if you really ask them how, if they're having any type of symptoms back, and we're trying to be very strict with regards to classifying any type of recurrence. About 5 months, a lot of patients will actually start reporting some type of recurrent symptoms. It may not be even close to what it used to be, but these nerves technically can generate very quickly, and at some point, about 90% of them will want additional treatment. So it is always something we keep in mind to potentially look into additional ways to really just manage these patients long-term, knowing that we're going to kind of walk with them through this journey. Well, I very much appreciate both of your time and expertise and just amazing, insightful discussion. Thank you very much, and have a great day, both of you. And we're going to move on to the next component of the talk. Thank you both.
Thanks so much.
Thanks.
Okay, we're going to move on to the second part of our talk, and this is going to be a very different focus shift. This is going to be called Harnessing Technology for Patient Education and Practice and Marketing. And here is the crew for this group. This is me again, and I'm very honored to be joined by Dr. Tom Higgins in Louisville, Kentucky, and also Dr. Puya Degani Mubaraki from Italy. And they are both experts in practice management, and they're going to share a lot of their amazing insights with us today. So thank you both for being here, and welcome.
Thank you. Can you see me?
We can see you and hear you.
Excellent.
Puya, you want to give it a try?
Good morning, Edward. Good morning, everyone. Thank you for having me in this.
Awesome. Perfect. Sounds good and looks good. So we're going to start with talking about websites. Okay. Both of you have outstanding websites and a lot of experience managing these. Okay. So these are some examples of websites that we're familiar with in the domain of rhinology. How do you utilize websites to educate your patients? Puyo, I'll start with you.
So thank you for having me in this, and thank you for the invitation from your side and from the American Rhinologic Society. I'm the president of Nasal Association. We are focusing on not only on research, but also on educational and implementing education throughout technologies. So in particular case, I think that the use of the web nowadays, because of the software that we're using, because of the mobile phone that we're having, it's essential not only for educating patients inside of your institute, but also for disseminating the information throughout technologies worldwide, simultaneously, and just by one click. I think that the tremendous amount of information that has been developed and disseminated now in the last 10 years are simply amazing compared to 20 years ago. And I think that the social media enrich this by implementing not only the use of the software, but also for how to change the path from the younger generation also into the older generation. I think that everyone knows by now how to use a QR code. This was impossible 7 years ago. I remember 7 years ago producing a QR code. The people were just saying, oh, what are those images? And now the people just know how to address and use QR code, get into a place, just watch, get information, and disseminate with just with one click. And I think that the education of our colleagues are not only for benefit of themselves, but also for the patients, because the same thing that we are watching now can be useful for the patients. Imagine YouTube videos, educational videos on how to use not only equipment, disposable instruments, but also how to use and to proper use the drops and for example, nasal rinse, how to use the nasal rinse, how to perform this, how to use the nasal spray. All those information are needed when it comes to education for patients.
Excellent point. I think it really broadly touches upon a lot of the other modalities that we're going to also be touching upon, but definitely education both for patients and other providers, and technology has really played a large part of that. Dr. Higgins, with regards to marketing your practice and services through the web, what has been your experience? What are some strategies you can share with the audience?
Well, a website is your sign to the world, and it's the hub for what you want to display to that world. And so with the website, he was just mentioning YouTube videos and social media. Well, you can start with that website because people are trying to find you. From a practice standpoint, you want to have a website that makes it easy for the patients to find you, and also easy for them to make appointments. So it's not only appealing from the look aspect, but also functional. And so having and also being able to display to the world or to the patients that you are wanting to see what types of services, what procedures maybe you do, what type of conditions you concentrate on, and then that helps people find you, but also helps them get in to get the care they need.
Great points too. Again, websites more and more so important, and I think a lot of patients are very adept at finding websites and using that as the first point of contact. Just very briefly for each of you, just maybe 1 point each, what tips do you have for providers who want to start a website? Dr. Degani, I'll start with you on that one.
So I think that the images you're providing are essential by now. Videos, instructional videos. I think that information should be tailored upon your audience, because if you are having the majority of your providers, which are a child, means under 12, and their parents, you want something that should be reliable onto them. So more cartoony style, I would say more easily affordable information for children, but also at the same time try to avoid all these crazy YouTube videos or Vimeo videos in which laws and information could be related to endoscopic procedures. So more essential videos, informative videos, and try to educate patients. I think that one thing that you would establish is the relationship between you as a doctor and as a teacher with your audience and with your patients. I think that this is important. Confident, and try to be yourself. How to distinguish yourself from somebody else. You don't want to be like somebody else. You have your brand name, you are your presenter, and this is your name that should be shared with everyone. So try to be more essential as possible with a good information for your audience.
Strong points there. Dr. Higgins, how about you?
So I think one, when you're starting the website, you need to think about your time and budget. So you can go as simply as taking a template. There's a lot of templates out there. There's a lot of platforms out there to get you started. And if you wanted to build it yourself and get something started, you can certainly do that. If you don't have the time and you have a little bit more budget, you might be able to get an agency to create something that's even more professional, because one thing you want to make sure it is professional. But there's other elements that play a role, because a website should be a dynamic platform. So meaning you need to constantly be adding content to it, whether or not it's graphics, videos, writing, blogs, and that helps to keep the website alive. So you want to be thinking about that. The other thing you need to think about, particularly in the US, is HIPAA compliance. So your forms on most platforms are not HIPAA compliant, so they don't have the encryption. So you want to make sure that you're considering that. And so in particular for a website from a HIPAA compliance standpoint, it is the forms, it's the communication type of things. And there's a lot of different also elements that you can add to it from a compliance standpoint, ADA compliance. There's also web chats you can add, any ways to make it easy for a patient who's interested in seeing you to communicate with you easily.
Awesome. Well, websites, again, play a very strong role, and I appreciate your insights and sharing this with the audience as a lot of us continue to modify and build on our own. We'll move on to the next category of other technological things that we have in our practices. So both of you are very involved in webinars as well. So how do you select webinar topics? Dr. Higgins, we'll start with you.
Sure. It goes back to what is your audience? So I've done webinars for doctors, for patients, and those topics are going to be dependent on that audience. And within for doctors, it could be what specialty are you talking about? It could be your own specialty. So obviously you kind of have an idea. If it's rhinology, you kind of have an idea of topics that may be of interest. A couple of things from that could be research coming out, but it also could be hot topics that are coming on. For my organization, the Snot Force Alliance, the mission is to bring specialists together to treat sinus, allergy, and airway conditions. So we actually overlap with some specialists. So there may be ENTs, allergists, pulmonologists, GIs, because we all see patients that have similar symptoms, but we see them in a different way, and there may be ways of collaboration. And so a lot of times that's where some of these topics come about, where just these discussions. And actually a webinar, while you're doing a webinar, all of a sudden more topics come up because you realize, I don't know a lot about that. And so that becomes a great topic to do in the future.
Awesome. Dr. Gianni, how about you? You have a lot of online webinars as well with a lot of expert speakers. How do you choose these topics?
So I think that when it comes to planning a webinar, is not only for providing the best presenter, of course. It try to establish what is the needs in a particular moment. So there was a certain point in which, for example, during COVID, we were already running out more than 60 webinars online. But at some points, the needs was we cannot have any dissection course, hands-on course, anything that could be for training. So why not using this moment to present, for example, a step-by-step procedure like dissection or whatever it is. So imagine this. So I think that the situation between the differences between Europe and United States and the rest of the world, especially when it comes to Italy, are legal issues. Dissection courses were not able to be performed in Italy unless you were providing cadaver heads or whatever other specimen from the US. So by now, the people were used 15 years ago to move, for example, in Spain or in Austria or other places around Europe to do and attend dissection courses. Nowadays, this can be modified somehow, and you can have the possibility to watch everything, not only online whenever you want, but with the best quality, 4K images. And you can also rewatch it again without moving yourself. It doesn't mean that you don't have to attend training courses. It's just that by now you have the possibility to expand yourself and be updated. It's not possible anymore. We cannot complain or blame other people because they don't want to do it. You have the possibility. It's free. You just need to attend this. So when it comes to topics, then you have the platform. You change the different section from hands-on courses to rhinology to biologic to histology. Not only on this, as Theodore previously said also. So you need to specify what do you want in a certain point. Of course, one thing that should be needed is that the update that you have or you need is at least from 10 years maximum, because everything changed. The research, imagine this, the impact of olfaction research in the last 5 years completely changed from 10 years ago. So you need to keep updated your webinar time by time.
Webinars have become very, very popular and very, it's a really good way to especially disseminate information, especially if we're with our international colleagues across different time zones. And again, has played a very large part since COVID. So, just been amazed by some of the work that both of you have done in this domain. So thank you so much for sharing that. I'm going to move to a different modality. So social media, another somewhat different but related place to put some of our information, put some of our practice information, and to reach out to patients. So, Dr. Degani, I'll start with you. How do you utilize social media to educate patients and to market your practice and services?
So should I start?
Yes, please.
Oh,
you
sorry.
Go ahead.
So
yeah.
So when it comes to social media, I think that Thomas said something really good. It's the algorithm and the frame that you're using, the things that you want to post are a little bit different. You cannot compare, for example, TikTok to Instagram to Pinterest to YouTube. All these somehow are related and connected. So you want to make sure that you're connecting all your accounts in once. But the content that you're posting, for example, when it comes to live, you know that we're doing a lot of live webinar. The algorithm is not the same when it comes to live from Instagram compared to LinkedIn and Facebook. So I think that one thing that if you want to step your game up is to post content, a lot of content. I remember 10 years ago, when I was talking to people about the use of Instagram, they were like, "Oh no, so you will not do this," or TikTok. Of course, I'm not into that TikTok. The technology behind that is crazy, amazing compared to Instagram. But at a certain point, Instagram, in my experience, has not been that impactful when it comes to the association, of course, compared to YouTube. It depends on what you want to disseminate. Social media are fine when it comes to information, but for education, a webinar, not all of them are tailored upon your interest. So when it comes to webinar or videos that are longer than 2 minutes, I would go for YouTube, I would go for Vimeo, I would go for Facebook. When it comes to this podcast, of course, I would go for Spotify, I would go for YouTube, I would go for Google. When it comes to short reel, I would go for Instagram. Short reel means everything that is from 5 seconds to 15 seconds. The content between 15 seconds and 30 seconds is completely different. Nobody wants information that are longer than 13 seconds, unless those are the people that are, that you have established a good relationship and they trust you, because the information you're going to provide needs to be heard in a frame time that is more than 1 minute. For example, for LinkedIn or Instagram or WhatsApp, those are not only social media content creates like platform. Instagram or Telegram should be used for disseminating or making advertisements. So all those social media are different in my opinion. How about you, Thomas?
Yeah, thanks. So social media, you want to think about the purpose of what you're planning on doing. And it really helps to amplify and engage your audience. So it could be patients, again, it could be doctors. And you want to think about how you're going to do that. You may not put an hour-long webinar on Facebook or Reels, right? But you could put snippets of that webinar, or you could engage people to say, we're going to have a webinar. So you can get people on these different platforms, or if it's patients, You can also engage, and I call it advocacy, create an advocacy group of your patients, and that helps to amplify what you do. They may say how great you are as a doctor or whatever like that, but you also have to be careful, right? You need to be careful of what you post on there. You can decide on how much you want to do, but if you don't want to get necessarily political, or you don't want to go and talk about an individual patient or anything like that. And so, but you think about that different purpose, and as was mentioned, the different platforms have different purposes, and so you have Facebook that you can get out to patients. You have TikTok that you can do little bitty, really short videos, as well as reels. YouTube, you can do both. You can post the whole webinar on YouTube, or you can do it as shorts. I don't think I see oh, there it is. The LinkedIn. LinkedIn is for your professionals. And so as a physician, particularly say if you are a specialist, whether or not you're ENT, rhinology, laryngology, anything, you can, when you post on LinkedIn, it also can help out with your referral patterns, because on there, you're going to have potential physicians, providers who would refer to you. The other thing that I don't see on here is email marketing. Now, that's not social media, but I utilize email marketing as well. Again, that goes back to HIPAA compliance. And you don't want to market individual patient conditions and stuff, but you can certainly, if they opt in to your email marketing, then that's a way that they can look at your emails and get information on when they want it. And if they don't like it, they can always unsubscribe. You want to make sure you go through all those policies. But I think email marketing is a really good way of expanding that reach, especially if you think about your whole program. If you're going to do webinars, if you're just trying to, again, what is your purpose? Are you trying to get people on webinars? Are you trying to get people to make appointments? And then thinking about all of those different purposes, then you can utilize each of these in different ways.
Awesome advice. And again, social media is such a big part of what we do as well. You see lots of different accounts, even just for practices, physicians. There's personal accounts, there's business accounts, there's also society accounts at this point. And I think we're going to see a lot more development over time as people become more familiar with this. So definitely appreciate you both sharing your expertise on this area. In the last 2 minutes or so, I definitely wanted to cover this topic at least very, very briefly. Okay, so what do you guys think are on the horizon, and how do you currently use it in your practice? Dr. Higgins, I will start with you on this one.
Sure. So you almost need to think of artificial intelligence as augmented intelligence. And you think about when we're utilizing it, if we utilize it as a physician, and in medical care, that you're using it to enhance your medical capabilities and how you practice as a physician. And I've seen several ways where it can. I think from a either educational standpoint or a resource, it's going to change the way we are able to gather information. So instead of just a single page or book that we're looking at, what is the latest research on this, we'll probably be able to gather, or we're already able to even gather a summary of that research. But in general, you're going to still see the patient in your clinic, and you're going to be tailoring how they need to, you're going to be tailoring their medical care to them. And so you don't want to lose sight of that because medical care is not only a science, but an art. And I think that will be kind of how we're utilizing it. Another really beneficial aspect about AI right now is saving time on documentation. And I think some of you all have maybe used any sort of ambient AI technology. There are several ones out there, and that allows it to kind of listen to the conversation and summarize the visit, now saving you time of the documentation. And sometimes you can be even a little bit more thorough on that documentation because there may be some things you otherwise may have even forgotten or you wouldn't have put in there. And I've definitely noticed that. And then you read it over afterwards and make sure that it's exactly what it needs to say. But that can save time and then allow you to be more efficient in the clinic.
Thank you so much for sharing that. And then Dr. Tigani, how about you for AI?
So there are pro advantages and contra advantages, of course. Regarding the briefing for meetings or whatever, as Thomas said, it's beneficial, of course. Then you have everything done and recorded and stored, and it will help you a lot. But when it comes to artificial intelligence for purposes of information or informative for patients, it will, of course, save you time. There are some things that should be also always double checked, because we have seen throughout also the literature, if you just watching all the checking out on PubMed, you will see a lot of articles lately regarding artificial intelligence, for example, for recognition of cancer imaging and how the implementation of cancer and imaging guidance will help you to recognize cancer. But when it comes to practice, we've seen virtual consultation. Some of those virtual consultation can be made for some of the purposes. For example, when it comes to questionnaire or asking patients as a follow-up, but of course will not change or will, replace a virtual, subjective consultation. Artificial intelligence, I've been using this for providing information for patients, or for example, when you integrate in your software for emails and will respond you automatically. But you need to assess initially what are the purposes of this and be clear with the software what you want to provide. Otherwise, if it's just not connecting very well, we always are forgetting about legal issues. Want to make sure that everything you're using is under law jurisdiction. And I think that this is important. It's something that we should keep in mind. Legal issues or legal judgments with artificial intelligence. And this is not balanced, by the way, in Europe. I don't know how about the States, but over here is a balance stuff that is not being recognized very well.
The entire topic and the entire domain itself, it's always evolving. So this is again, very hot topic. And again, both of you have shared a lot of amazing expertise. We are out of time today though. But again, I want to thank both of you for sharing this with us. So a lot of us have either a platform to start building our own presence online or in marketing. And also for those of us who already have it, these are some great tips to draw us forward. So thank you both for your time.
Thank you, Ed.
Of course. I'm going to move on to the break, and then I'm going to also introduce my colleague, Dr. Ashley Halderman, who will be leading the third session. So thank you both very much. All right.
Thank you.
We shape the future. We continue to care for the well-being of patients, and we treat everyone with respect. We are trustful, accountable, and we continuously strive for improvement. We encourage strong and thoughtful decisions, and we care about our environment. We are a 100% family-owned business with technological expertise ranging from optics, mechanics, electronics to software. We are a recognized solution provider for endoscopy, delivering customer-centric added value. We leverage comprehensive data and streamlined processes to drive our business. We are Karl Storz. And we empower individuals to become engaged employees. This is why we all come to work every day. And this is why all our customers trust our solutions every day. Because we're leading to solve core customer needs. Because we're offering a unique portfolio. Because we're acting as a trusted advisor. And because Karl Storz is living our commitment to reliability, quality, and availability all the time. With our values, our vision, and our value proposition, we shape the future. We shape our future.
Surgeons rely on technology to achieve their primary goal: positive patient outcomes. OR technology advances rapidly, so surgeons need one solution that can keep pace to remain state-of-the-art. One scalable video system evolves with advancements in technology. A modular design philosophy with software enhancements that adapt to changing physician techniques, serving multiple surgical specialties. Image 1S provides surgeons with exceptional visible data. Software enables 3 NIR ICG visualization modes to meet procedural needs. Surgeons can choose between fluorescence settings to assess perfusion and visualize critical anatomy. All designed to improve overall outcomes. NIR ICG visualization is now possible in 4K 3D. Restored depth perception enables precision, resulting in reduced operative time and errors. Plus, AI-enabled software for digital horizon control to keep orientation throughout surgery. Exoscopes, enabling ergonomic open procedures, can be easily incorporated. Choose between fiber, digital, and single-use flexible video scopes, all within one system. Your patient, your choice. Image 1S offers one scalable modular method to deliver data that creates pristine imaging, meeting the specific needs for every minimally invasive surgical application. Realize the value of one to reduce your surgical video costs and buy what you need when you need it. Let us show you what's next in visualization data and information acquisition for today and tomorrow.
Patient care is no longer contained by the walls of a hospital. As technologies advance, more treatments can be done outside the operating room, and patients are reaping the benefits of early intervention and less invasive care. Innovative technology from Karl Storz is enabling healthcare providers to respond to the migration of patient volumes from the OR to the outpatient setting, delivering greater efficiency, convenience, and cost-effectiveness all around. Our broad portfolio includes compact endoscopy systems like the Telepac Plus with Stream Connect that can turn any space into a site of care, enabling seamless connectivity across the enterprise. Our new technology center can help you explore workflow opportunities. We can design to cost, size, and ease of use based on your patient population and procedural focus. We invite you to experience it in person or virtually. Create a customized installation that meets your financial goals while improving workflows, clinical outcomes, cost of care, and ultimately, the patient experience. The possibilities are limitless.
Hey, Nikita.
Hey,
Can you hear me?
I can hear you.
How you been, man?
Good, good. How are you?
I'm doing well, doing well. I heard you had a baby. Congratulations.
Thanks so much. Dr.
I was,
Hollerman, we can't hear you.
yes. Yeah, we cannot hear you. Oh, there's like a little bit of delay in the video.
Can you hear me now?
Yes, we
Yes.
can.
Okay, excellent. Okay, so we're gonna get started. Sorry about that, everyone. Thanks for staying with us this morning. It's now kind of the afternoon, or depending on where you are in the world, evening or morning. So we're gonna start with best practices for initial management of nasal polyps. And not to be too dramatic, but I think that this is a crucial topic at a critical time for the field of otolaryngology. I'd like to introduce, myself, I'm Ashley Halderman, moderator today, and thank you so much to my panelists, Dr. Nikita Chapurin from the University of Florida School of Medicine, and Dr. Camilo Reyes from Emory University. Nice to see you guys.
Oh, hi. How are you?
Thanks for having me.
So we're going to start off with kind of a burning question. And I asked this because I want to kind of frame this topic in a couple of ways to get some messages across. So for my panelists, when patients present to you with recurrent or persistent polyps, what are the most common reasons why they have failed? Well, go ahead, Dr. Chapurin.
Sure, yeah. Well, I would just like to take a step back. I mean, being at a tertiary referral center, I mean, we kind of get referrals from all over the place, primary care, other ENTs. So, first I would like to, I usually like to confirm the diagnosis that they actually have polyps. But then kind of more broadly thinking about why patients fail, are they on appropriate medical therapy? That's one, because that's not always the case. And then if they had surgery, how complete was the surgery? Is the surgery appropriate? And things like that.
Okay, Dr. Reyes.
Yeah, for me, I generally try to get some idea of also, a tertiary referral center, but sometimes I want to get like an idea of what type of endotype the patient has. Because, as most of us know, it depends on the degree of the disease. And some patients, they haven't had maximized therapy. If they have, like you said, recurrent persistent polyps, hopefully they'll have a scan. So I go through the scan and make sure that, they have a proper FES, make sure there are any partitions or any causes of obstruction. Then I ask them what I generally I don't ask them hey, are you using your medications? I ask them tell me what you're doing every day. Tell me what are the steps, what are the medications are you using? Obviously, really important for me, I always ask them if they're smoking. And a little bit of background, because some of those patients, for whatever reason, they haven't been properly diagnosed on the type of endotype. So it's asking the proper questions. Some patients may say, oh yeah, do you have asthma? No, I don't have asthma. So you had asthma when you were a kid, and let's say you outgrown it. It's yeah, my mom told me that I had asthma when I was a kid. So then I ask the next question, do you have any allergies to aspirin? They say no. Oh, okay, what about ibuprofen? Oh yeah, I do have a sensitivity to ibuprofen. Or I go into their diet and say, hey, okay, you don't have any allergies to NSAIDs. So I said, hey, maybe you go at night, eat some pizza and some, tomato-based meals and beer, and then how do you feel the next day? Oh yeah, I feel really congested because there's some meals that have a lot of salicylates in their diet, especially greens. That's what they say, greens are good for you, so broccoli and all that stuff.
Okay, yeah. So a couple of consistent things, let's see here. So, when I first see a patient, and you guys both of you hit on this, I would say that a fair number of patients have failed prior management in part because they had incomplete surgery and were not surgically optimized. They were not medically optimized. There was a failure to perform maintenance therapy with topical steroids for any extended period of time. And then there's, of course, true recalcitrance. And I think you guys both hit on something that is important I didn't include, but deserves notice, which is questioning the initial diagnosis and the correctness of that. Out of all of this, I was surprised at how often I saw these things. And patients who were not surgically optimized, incomplete surgery, not on topical steroid rinses for a long period of time, had stopped seeing their otolaryngologist after 6 months post-op, and just weren't sort of meeting the standard of care that I would like to see in polyp patients. So I think that this is a time of reckoning for the field of otolaryngology. We may have been missing the marks in some ways. And I would say that in my experience, true recalcitrant disease is actually pretty infrequent. I don't know if you guys would say the same.
Yeah, I mean,
It's there.
Is there. I mean, I would say that from the clinical standpoint, you're right. Sometimes I'm pretty sure that all you have seen those patients that they're doing everything as they should, and then you scope them and you see like polyps here and there, but they're completely asymptomatic. The sense of smell is normal. They're not complaining of nasal obstruction. They're not complaining of like dysgeusia, any symptoms. It's just like clinically they're asymptomatic. So yeah, I will agree with you with that.
I think it's also a moving target. I totally agree with you guys. We used to say maximal medical therapy or maximal surgical therapy. Well, I mean, I think we've gotten soon nuanced, and we have so many new, both extended procedures and biologics and other things that, there's really no true maximal therapy anymore. I mean, we're talking about appropriate medical therapy, appropriate surgical therapy, and it varies depending on, your training and philosophy and things like that. So, yeah, I think it's pretty rare to see someone who's like truly failed maximal everything. And that definition is kind of hard to kind of pin down to begin with, but it's very much. Yeah.
Okay, so next question, agree or disagree? Chronic sinusitis with polyps is a chronic inflammatory condition which requires active treatment, maintenance therapy for the long term, typically. Would you agree or disagree?
100%. Yeah, and I
agree, right?
We spend a lot of time with our patients talking about, there's no cure, right? This is kind of like asthma. There's inflammation in your nose, kind of like, you have to have an inhaler. I see you mentioned hypertension here. We use that sometimes too in discussions, but you kind of have to have that big talk with the patient. There's, a surgery or medicine or even using a nasal steroid spray for 6 months is not even going to provide you a cure. So compliance is really key.
Right. Well, and so this kind of comes into my mind when I'm seeing these patients who stopped following up with their ENTs and were not on topical steroid rinses, which I don't know if you guys would agree. We're going to get to this a little bit later on, so we'll just wait on this. But to me, that is appropriate maintenance therapy for CRS with polyps. Again, I'm like, okay, is this just patients sort of ignoring this conversation we're having, or are some providers not having that conversation with them and not kind of thinking of this disease process as a chronic medical condition? So I wanted to kind of talk through your approach. We're starting with just a brand new polyp patient. Nobody's touched them before and no prior treatment. So I want to know, and you've touched on this a little bit for kind of recalcitrant cases, but what's your initial workup for a patient that comes in, is symptomatic, and has this finding on nasal endoscopy? Dr. Reyes?
Okay, I'll go ahead and start. Okay, so initial workup, like I previously explained, a thorough medical history, obviously nasal endoscopy, ideally CT scan if they already have it, for me, it's really important to know if obviously the polyps are bilateral or unilateral. Because when it's unilateral, then you have to think about different things. I mean, probably you've seen all those patients that they thought it was just a polyp, and then it comes back as an IP. So, getting those ideas in your head. I routinely don't do labs like measure, IgE and peripheral eosinophilia. Regarding imaging, just a CT scan, and that's it. And for me, it's like physical exam, imaging, CT scan, and a thorough medical history. And I will leave it to Nikita to see if he has any other thoughts.
Yeah, would you add anything to that? Do you anything different?
Not much. I mean, I would just say, kind of highlight just listening to the patient. I mean, a lot of times they will tell you things that will help you make the right diagnosis. I mean, kind of like what Dr. Reyes was saying, screen for, NSAID sensitivity, really talk about asthma. If there's, I typically don't get routine labs unless I suspect that there's some sort of other systemic illness at play, vasculitis or, if they have really poorly controlled asthma, or I suspect that their asthma is not diagnosed, I'll get PFTs. But, nothing routinely unless there's high suspicion. But I think it's just really key to just spend a decent amount of time for the first time you're meeting a polyp patient to just sit down and listen and hear the story. And a lot of times they'll tell you exactly the way you need to go.
Okay, excellent. And I'm the same way. So, okay, that person comes in, they're symptomatic, they've got polyps. What do you do? So we mentioned imaging, not really getting labs. What's your initial sort of treatment? Dr. Shapiran.
Sure. So I think that the current evidence and guidelines pretty clearly say that some form of nasal corticosteroid spray is a must, pretty much. So I make sure that they're on, fluticasone, romedazole, some sort of nasal spray. We know that nasal saline rinses, lavages are very effective as well. So those are pretty much a must for both maintenance and treatment as the first step. There's been a little bit of a paradigm shift. We kind of used to think that chronic sinusitis polyps, we used to think of it more of like an infectious etiology. Now we know it's mostly an inflammatory process. So, the role of antibiotics is, I would say, kind of controversial. But we do know that oral corticosteroids work really well. So, before we kind of, even before I get imaging, I put them in a course of oral steroids to try to see if we can knock down some of the inflammation. In terms of antibiotics, I do like to trial doxycycline. There were some interesting randomized control trials out of Europe and here too that showed that doxy and antibiotics in the same class do have some anti-polyp, anti-inflammatory properties, and there is a whole thought process of staph and enterotoxin toxin potentially contributing to CRS. So doxy is a good start, especially if I see mucopurulins to treat both the anti-inflammatory component of the disease, and then also possible superinfection. That's my go-to.
And Dr. Reyes, and actually we're going to touch on antibiotics in a little bit. So what's your sort of initial go-to treatment course for these patients?
Yeah, I don't have a lot to add other than what Nikita already mentioned. Like I said, the patient that I usually see are patients that have been bouncing back from ED to ED. And as you all know, the ED cocktail is always like steroids and antibiotics, and those patients keep on bouncing. And I think that's really important what you mentioned previously about giving the example of hypertension, explaining that there's no real cure for this disease. And the patients need to understand that. And once they understand that, they get a little bit more engaged. But when they sometimes they come in already really discouraged because they've been like from ED to ED and I never get well. I go to the ED, they say I have an infection, antibiotics, steroids, I get better, and then they come back. So generally, if I see a patient who has like pansinusitis, both cavities filled with polyps, I would just go straight to surgery. I just explained that to them.
Right, grade 4 polyps, I'm taking them to surgery. Most other people, especially if they're treatment naive, I'm going to test them with steroids and see what their response is. And then generally I try to follow up an oral burst and taper of steroids with an immediate initiation of topical steroid rinses. Okay, and so let's say that this is kind of just a straightforward polyp patient. You tried your first course of treatment. When do you see them back? I see them at a month.
I see them in 6 weeks, but yes.
Yeah. So somewhere between the 4 to 6 week period, and you're assessing what their response was to that treatment. And how do you define success for these patients? For me, it's, are they feeling better? But it's not just, are they feeling better right then and there? It's how long do they sort of maintain an acceptable level of symptoms off of oral steroids? I guess, do you guys have anything different?
I would just stress that, patient-reported outcomes. I mean, because we know there's a not strong correlation between endoscopy findings and imaging findings sometimes. And, we all have those cases where, a patient comes in with grade 3 polyps, pansinusitis on the CT, and they're just fine. They don't want surgery. They don't want to do the rinses. They don't want to do the sprays, and vice versa. You see a scan with someone who you think has mild to moderate disease that are absolutely miserable. So I think ultimately, kind of like you said, Dr. Hallman, you just have to listen to the patient. I mean, a lot of times they'll tell you, am I happy or am I not?
Mm-hmm. Right. Do you feel better? Are you okay with your level of symptoms? To me, I'm not looking, unless there's like a mucocele or some sort of impending complication from sinusitis. I'm treating the patient, not the scan and not my endoscopy. Okay, so let's say that they responded to a course of oral steroids. Do you just is there a cutoff to which you will sort of give courses of oral steroids? I think we're all really cognizant now of sort of keeping that level within a acceptable range of lifetime steroids. For me, it's random, but it's like, if you need more than 2 courses of steroids per year, then I'm going to actually sort of really push you to the surgery route.
Yeah, I mean,
like similar to what you guys do?
Yeah, especially, like sometimes with biologics, insurance companies want to hear, oh yeah, have they tried steroids at least twice a year? Or I'm not sure if it's twice or 3 times a year. And yeah, I mean, like if a patient has already had steroids more than once, I would start discussing with them.
Same. I think I'm becoming more cognizant. I mean, there's a lot more literature now coming out in terms of cumulative steroid dosing over a lifetime and how that can increase the risk for cardiovascular events and things like that. The number always changes, but somewhere around 500 milligrams of prednisone equivalent or something along those lines. I mean, there's not a concrete number. I think you kind of have to take everything down. And in terms of when the follow-up, I like to wait a little bit longer, because sometimes they go through this honeymoon phase, when you give them steroids and antibiotics. So sometimes I'll intentionally see them 2 to 3 months or so, just sometimes they'll come in and they feel great because they just finished the steroid course.
Failed,
and then the next
right, and if they failed within that period of time, to me, that's okay. You're going to need steroids every 3 months or so to feel this good. That's not an acceptable response to me, I guess. Well, I want to make sure that we touch on surgical management because I think that this is something that is being underdone or sort of not optimized in a lot of polyp patients. So, surgical therapy, the entire point of it in polyps is to deliver topical steroids into the cavities, into the sinuses. And that's not going to be optimized with incomplete ethmoidectomy or this central cavity endoscopic sinus surgery like what is shown here. And I think there's this very human tendency to try to avoid the injury to the orbit and injury to the skull base. And so you sort of, get yourself into this little hole to kind of work your back to your sphenoid, when the reality is you need to be seeing and skeletonizing the lamina and the skull base in most polyp cases. So this is kind of what to strive for. This is a patient, you can't really see that sphenoid opening on the post-op scan, but it was widely open. But I've really skeletonized my skull base there. And then this is sort of the endoscopy picture where you can see that I've really nicely skeletonized the orbit. And so in this case, where I've got my middle turbinate is medialized, my middle meatus is nice and patent, I feel very confident that topical steroids are getting into these cavities. So would you agree this is kind of what you want to strive for in polyp cases?
Yeah, definitely. I mean, and like you mentioned, generally what we see on those patients that had failed surgical treatment is like you all have all those septations along the skull base, especially because, again, we were all there. We were all residents, we were all trainees, and we were afraid of going to the skull base. And, you know, and that's what we generally see. There's some septations along the skull base and along the lamina. And I agree, like that's an excellent outcomes. That's what we're striving for. And like you mentioned already, like the reason that patients fail is because it's like there's some septations up there.
Right. Yeah, I tell my trainees that, it's like the facial nerve in parotid surgery. Why do you find the facial nerve? It's to protect the facial nerve. And so I kind of have that same theory for, the lamina and the skull base. So I want to ask you guys, what dictates the extent of your surgery? So again, this is the first time polyp patient. Are you right off the bat doing extended approaches or only doing those for certain cases? Dr. Chapiran?
Yeah, thanks. Yeah, I think you guys bring up really excellent points. And I think that take home is not every surgery is created equal, and you have to kind of tailor your approach to the patient. So, especially if we're seeing, grade 2, 3, 4 polyp patients in clinic, those are not great, balloon candidates. They're not great, mini-FES, OMC kind of surgery candidates. I think it's critical that, kind of like you were mentioning, a lot of this is opening up the natural drainage pathways to the maximal extent. So you have to do a full house surgery, create big openings. And then, I don't typically jump to extended approaches right away because there's definitely, I would say the majority of our patients respond really well to a good, thorough, sphenoidectomy, frontal lesions dissection, and don't necessarily, if they're compliant with medical therapy, don't need no surgery. The extent of surgery is kind of interesting. I mean, there's a lot of more research happening and now. Penn Group just, published their, completeness of surgery assessment kind of paradigm. Oh, okay. Yep. And then.
Oh no, go ahead.
I was just going to say,
yeah.
There's questions about whether middle turbinate, partial middle turbinate sections help as well. So, I might do that and make sure we kind of do a good full house, maybe partial middle turbinectomy, open up everything widely, but not necessarily jumping to a draft 3 or anything like that.
For an initial polyp case, I think that's fair. And sorry, I changed the slide because I think the two main things that we talk about as far as extended surgery for polyps is going to be middle turbinate resection and the frontal. So Dr. Reyes, what's your approach?
No, I mean, I just wanted to add, I mean, it's like the extent of surgery is sometimes a difficult question because we're looking, like at CRS with nasal polyps. But for me, it's definitely, let's say, like a different animal between eosinophilic CRS, ARD, and AFS. And here, in the South, in Georgia, we see a lot of AFS. And those, I always tell my residents, like the principle of this disease, like it expands everything. It like pushes all the cells to the side. So you have to like be really meticulous about getting to those specific cells. For the eosinophilic, patient, you can, maybe you can leave some septation behind. For the ERD, you cannot get away with that. And also the patient's anatomy, specifically talking about the frontal sinus. If they have a narrow frontal sinus, they have a wide frontal sinus. If they have a narrow frontal sinus, you can do a frontal sinusotomy, but they're probably not going to get medication there. So you want to expand it a little bit more and be more aggressive. I recently moved from Augusta to Atlanta, and is definitely a game changer. The type of population that I'm seeing there, I'm still learning. And I've done some frontal sinus on patients, and they're like open, and then they come back and they fail. I'm like, my God, what they fail? Well, a lot of patients are not taking care of themselves, and they're smoking. I'm seeing patients in downtown Atlanta. Yeah. So it's something that we really important to consider as well if their patient is going to be adherent to the management.
All right, so I want to unfortunately, we're running out of time, so I wanted to touch on postoperative care. Are you guys doing topical steroid rinses in these patients? Yes, no?
Absolutely.
Yes.
Yeah. How long do you do them for? I do them for BID minimum of a year before I start to back off.
Yeah, I think it's variable. I mean, it depends on the patient and, you know, how their disease responds. I mean, there's definitely patients that, you know, you see them 3 months after and they already have some polyp growth. You know, for those patients, that might be lifelong. But, you know, if I do serial endoscopy, you know, starting with 3 months and then 6 months and then kind of go from there.
Yeah, you see them on a regular basis and you keep them in your practice for as long as they'll stay, right? It can sometimes get to I'm only seeing them once a year, but I am still seeing them because, again, this is a chronic disease process. Is that the same as your practices?
Yes.
Yeah. Okay, and I just wanted to shout out the International Consensus Statement on Allergy and Rhinology, Rhinosinusitis 2021. It gives you a really nice aggregate level of evidence for steroids, which you can see here. Antibiotics, you know, really, like you said, not a specific role in CRS. I tend to save it for either people who can't do a course of steroids and maybe are just looking for a little reduction of that inflammatory burden, or when I see mucopurulence. And doxycycline, because of the literature you cited, is my go-to. And so we'll just jump to the references. And thank you so much, gentlemen. I really appreciate this. Time went too fast.
Thank you.
Great points.
And
Thanks so much.
Thank you, guys. All right, so I'll have my next presenters go ahead and log in. And this next section is going to be, when should we use biologics for recalcitrant polyps? And I'd like to introduce two amazing women, Dr. Cecilia Damask, who is at the University of Central Florida, welcome, and Dr. Waywin Campbell, who traveled the farthest to be with us virtually, all the way from Australia. Thank you, ladies, so much.
Thank you. Thank you for having me.
Yes. So in the era of biologics, look, these are amazing options for patients who previously lived on oral steroids, and we've all seen them. And it was always kind of this sad, you know, eventuality in some people, or in patients whom steroids were contraindicated. At least now we have options for these folks, right? And, you know, I would say that the impact on sense of smell is exciting, but sorry to burst the bubble or ruin the honeymoon, I would say that misapplication in patients is really concerning. And, you know, I've seen this several times. It's not a rare occurrence, which is kind of bothersome, or kind of bothers me a little bit. And I'd say that these are patients who are not truly recalcitrant. They probably haven't had adequate surgery or medical management, or heaven forbid, incorrect diagnosis. I've seen this used in tumors. And so the tumor progressed while the patient was on a biologic. And also, you know, they failed to improve. Have you seen instances of this in your own practices? Dr. Damask?
Yeah, I mean, absolutely. I've seen patients who were diagnosed with nasal polyps and it was actually a tumor, and they waited 6 months or so. Patient wasn't getting better, maybe thought about switching biologics, and unfortunately, patient didn't find their way to me for like 9 months or 12 months afterwards. And I mean, that's devastating.
It is devastating. Dr. Campbell?
Yeah, unfortunately, I've not had that devastating experience. And I think it's because where we are, the prescription for a biologic is much more tightly controlled, just because we've got specialized healthcare. The government funds the cost of biologics, not insurance companies. And it is quite strict as who can prescribe them. However, I've certainly seen a lot of people who failed a biologic, but that was because, like you were saying before in your previous session, about the completeness of surgery. And we're probably going to touch on that, but we know that patients who have more complete surgery will do better with a biologic. And the way I look at it is surgery is like a biologic sensitizer. If you've had complete surgery, your biologic is going to be more effective. There's a chance you won't need it as often. You can start to space it out. and they're going to do better. And I can go into why that'll happen later. I don't want to burst your bubble too early.
No, we will get to that. And I would argue that, yes, cost is something that is, you know, the human cost of progression of cancer is unmeasurable, right? But financially, you know, unfortunately in the United States, otolaryngologists don't have to be part of the workup and sort of decision-making to initiate biologic therapy, which I think is a major issue right now. And we'll get to the slide I love to present to my allergist, which is not a polyp. It's a fun game we play. But, you know, the cost is way more effective to start with endoscopic sinus surgery, complete endoscopic sinus surgery, I would say. And generally, it's sufficient for more than 70% of polyp patients, along with ongoing and sufficient topical steroid therapy. So I thought that we could kind of best exemplify evaluation of a patient for true recalcitrance through a case example of my own. So we have a 53-year-old woman with allergies, asthma, nasal polyps, and AERD. Okay, so she's aspirin sensitive. She's had 2 prior surgeries. The last surgery was about 5 years ago, very short benefit from each. She only did saline rinses for about 3 months after each surgery. Currently, her asthma is very well controlled. PFTs are stable. She's on maintenance immunotherapy and Flonase and Singulair. So here are her images, and I'm sorry, I have a little bit of trouble with the videos on this. So I'm going to kind of play these, and you can go ahead and kind of speak to, you know, what your thoughts are already about this patient, what you see on the CT scan. We're going to go through it in greater detail in a moment. So this is somebody who's had 2 prior surgeries. And then hopefully I can go to my next one. Here's the sagittal. And so what are some things you've already picked up on?
Not really complete surgery.
A lot of cells left along the skull base.
Yeah.
And it looks like she's had very minimal surgery, and probably what she's had is a polypectomy more than anything.
Agree. And polypectomy is not, in my opinion, sinus surgery as we think of it. So is this case recalcitrant? So let's go through some things. So first off, that frontal, this is an AERD patient, multiple surgeries. It's not been opened completely, right?
Right.
I think it's fair to say that at some point in this patient, you need to start thinking about a draft, right? So improvement to be had there. In this case, and this isn't really mentioned a lot, but the middle turbinates are lateralized. And so I know that topical rinses are not getting into where they need to go. As you both mentioned, lots of partitions still in the ethmoid cavity. And here's a sagittal view as well. And so is this case recalcitrant?
Not yet.
What did you say?
Yeah.
Okay. And what are the various things that you've picked up on, and I'm sorry it's so quick, that would make you think, no, we can do better here? Dr. Damask?
So, I mean, it doesn't really, one, from a medical standpoint, sound like their medications have been optimized. They only did steroid rinses for 3 months. They're on Flonase now.
Saline rinses, not even steroid.
Oh, so yeah. So, I mean, definitely not medically optimized. And then on the other side, obviously would want to know more about their asthma. And is their asthma truthfully medically optimized? Because just because you're on a maintenance inhaler, is it just an ICS? Is it an ICS LABA or triple therapy or whatever? So I would say that they're, from a medical standpoint, not really optimized.
Thank you, because you are so good at asthma, and I don't spend as much time kind of managing and thinking about that, but it's a very important point. Dr. Campbell, would you agree with everything?
Absolutely. I think I have to say, though, this patient does need to be obviously more medically optimized, but given the background, the chances are the sinus disease is still going to need more extensive surgery. But with the medical optimization as well as the extensive sinus surgery, they've got a much better chance although this is that patient that is more likely to be recalcitrant, they just haven't proven themselves yet.
Agreed. Correct. I agree. Recalcitrant remains to be seen. So what would you do next if this was your patient? Dr. Campbell.
So exactly, get them medically optimized, and then that would have more extensive sinus surgery. I could only see those scans on that very small screen, but this is the
I'm
sort
sorry.
of patient, if you, no, that's all right. If they're looking at that more severe end of the spectrum of CRS, they're going to have extensive surgery with the frontals open, whether you do a drill out or I'm now modifying my drill outs a little bit to leave the nasal septum intact, but I am taking the intersinus septum down, and that nasal septum helps the penetration of the topical topical steroid rinses. Whether you do a modified medial maxillectomy or not would sort of depend on what you find at the time of surgery. If you've got that really thick eosinophilic mucin polyps and you can't get it out through a large antrostomy, I would then convert them to a modified medial maxillectomy. But this patient really hasn't had the chance to succeed at this point in time.
Mm-hmm. Yeah. Dr. Damask, how about you?
I mean, I agree. They definitely need some type of true good complete surgery, and then medically optimize them post-op and talk to them about the importance, like you did in the previous session, of this is an ongoing chronic problem of inflammation, and you need to do something to cut down on that inflammation and be on things like steroid rinses continually.
And I guess this is a sort of patient that, this is the sort of patient, because they have asthma, they'll understand this, and because they only rinse for 3 months before, I will often say to them, this is like asthma of the nose. My surgery is not going to cure you, but we're going to get the medications in with your surgery. And then they kind of buy into the fact that they're going to need to rinse most likely every day for a prolonged period, if not the rest of their life.
Mm-hmm. So we're kind of hitting both those points. So medical maintenance or optimization, which includes asthma, and surgical optimization. Now, I wanted to share this with the group because I actually saw in the questions about sort of like comprehensive and general ENTs and, you know, what role do we play? And I do think that the analysis of sort of post-op CT scans and the completion of surgery or the extent of surgery is a little bit nuanced. But this just came out of Penn. It was published in January, and this is the first sort of tool that we can actually use to assess the completion of surgery. And so you assign all of these different point values to each of the sinuses based on the completeness of the prior surgery. You look at the CT scan to do this. Previously, that was my own kind of method of going through it, but this has been validated and it's now sort of a clinical tool you can use. And I think it's really fantastic. And interestingly, what they found is that patients who had a score of less than 70, so maybe less complete prior surgery, they're going to benefit from additional surgery. So if you have a patient who scores less than 70, think about revision surgery. If they have a score equal to or greater than 70, then that's kind of a toss-up. They could have revision surgery, generally less improvement in their SNOT-20 compared to patients who are less than 70, or these may be patients that you talk about doing biologics in. So this is a really kind of newly published helpful clinical tool. And so I did surgery, and I'm going to go ahead and show the video. So she did amazing, significantly better in all areas. Got her sense of taste of smell, her sense back. She was doing budesonide rinses twice daily. But let's say that at 6 months, she comes back still doing fine. And this is her scope exam. So I did a Lothrop. I chose to do a Lothrop in her because, you know, the evidence does suggest that they may do a little bit better. AERD specifically, 2 prior surgeries, even though they really hadn't been maximized. But, you know, we're starting to see some accumulation of polypoid edema outside of the sinuses. The frontal itself looked pretty good and open. This is 6 months. So what would you do in this instance? She is doing BID budesonide rinses per her report. Dr. Damask?
What is she complaining of anything? Because just because we see recurrence doesn't mean we have to do anything, but how is she in terms of sense of smell? Is she happy?
She feels amazing.
Yeah.
Yeah.
And asthma is still doing well. Yeah.
Yes.
I mean, if the patient feels that they are doing well, you could increase the amount of steroid in your topical rinse if you wanted to. I really hate to do systemic steroids, especially in light of all of like the price data, the British Journal of Medicine article data about consequences of steroids. And so if she's not really complaining, I might reserve doing a burst of steroids at this point in time.
Mm-hmm. Dr. Campbell, anything to add?
Yeah, I guess the important thing is to ensure that she is irrigating with her head down. So I can demonstrate. I've got videos on my website, etc. And like Dr. Damas was saying, increase in the concentration of the steroid in the wash. But if she is being really compliant and she is irrigating with her head down, because it looks like the only area she's failed, correct me if I'm wrong, or not failed, but slight sign of recurrence is in that frontal. Everywhere else is probably looking fabulous. The surgery is not the problem here. This is the disease, as long as the patient is being compliant. It's very early on though. So that's the patient you keep a really close eye on. And I don't think, if we're looking at long-term maintenance here, I don't think looking at adding antibiotics or anything like that is the solution. So that's the patient where you see that early recurrence, you optimize them, and then I keep a really close eye on them to see if they respond to that optimized therapy or not. And if they don't respond, that's when I'd have that conversation about a biologic. But at this stage, didn't meet the criteria, at least not in Australia, to start a biologic. Not at this stage, because the polyps are very, very early, very small.
Mm-hmm. Right. So just because the polyps are back already, symptomatically, she's doing very well. She's quite happy. There's some things that you could tweak. Delivery, you could actually, I've had a few patients who it didn't seem to be getting there with the rinse. So I changed them to Xhance, and this went away. Or you can do direct installation of budesonide into the nose. It gets there, it can help. But that's more if they're kind of bothered by it. I am going to keep this patient under closer surveillance because of the AERD component. But, I would say that, okay, symptoms are going out of control. Polyps are worse. Asthma is getting worse. That's when I start to think, gosh, this person may be needing to get a biologic. So it's a very different clinical picture than just polyps are back, right?
Absolutely.
Yeah.
Okay. And so, I guess, are there certain patients who you do kind of consider for biologics? Not necessarily just off the bat, but are there people that you hold in your mind as like, these are good people for biologics? Dr. Damask?
I mean, definitely if the patient is very, very, very T2, has comorbid diseases like asthma, especially if their asthma is not well controlled. If they are patients who have recurrence early, like really early, and start being bothered, sense of smell, if they're very steroid responsive to that loss of sense of smell, then those are patients that, or if I actually got a pathologist to give me a structured report and comment on the eosinophils seen per high power field and they were crazy high, those might be patients I would be thinking about.
Dr. Campbell?
Yeah, exactly. That's a perfect answer. Textbook answer. It's brilliant. Yeah. It's those AERD, the AFRS patients, or as Dr. Damas was saying, there's ones with the asthma that's poorly controlled. We get a synoptic report on every single patient. Those ones with the eosinophils greater than 55, but particularly greater than 100 per high-powered field, who are already showing some fibrotic changes and charcoal-laden crystals in their mucin. I'm getting those patients ready already. But look, I always get surprised. There'll be someone who doesn't, often people do well without it, but I'm preparing those patients very early on.
So what about patients who don't have tissue or peripheral eosinophilia or elevated IgE? Are they people that you put onto biologics? That's a question I've always struggled with, because the literature, the studies have always been done. There's been an eosinophilic need, or IgE, and I've seen it used in patients who don't have elevation of these, and I'm always kind of scratching my head about that.
So if they, especially, well, so IgE, I don't think is the greatest predictor, and EOs specifically, they can be falsely lowered. Like if the patient had been on systemic steroids, their absolute eosinophil count could be down. And so that is just one snapshot in time. And like for asthma, like the GINA guidelines recommend that we test them 3 times before we say that there isn't an eosinophilic component. And if they have things that are very T2 suggestive, like they have other comorbid things, like, your patient had comorbid allergic rhinitis, and they have asthma, this patient had AERD, or if they have loss of sense of smell, if they are very steroid responsive, like if it's sounding like a T2 patient, but maybe the EOs aren't elevated, then sure, I'll think of it. But if it's someone where you're going in and you're seeing creamy, milky stuff mixed in with the polyps and they don't have any of these comorbidities, do I really think they're going to benefit from a T2 mediated biologic? Not sure.
Okay. I guess one thing I want to, it looks like there's a slide missing, so I apologize that, because I have the EUPHORA criteria up and I don't know where that slide went to, so apologies. It's a great resource. I would encourage anybody who is thinking about prescribing or working with patients with polyps to read that, where they have very specific criteria. One criticism that I have is that they mention failure of surgery, but this concept of completion of surgery is sort of lagging behind that information, and so it doesn't specify completion of surgery. But one thing that I want to ask you is, how do you define recalcitrance? Is there a criteria, or there's something in your mind when you see a patient that makes you think you're recalcitrant, I'm going to go the biologic route? Dr. Campbell?
Yeah, I think these guidelines are really helpful for defining recalcitrance. And for that, it's exactly going through these guidelines, whether it be EUPHORIA or the EPOS, as to sort of what you use. For us, in Australia, to qualify, your polyps have to have been greater than grade 2 on each side, and a total polyp score of at least 5 to qualify, plus a visual analog score for nasal obstruction of greater than 5, and an overall visual analog score of all of your symptoms of greater than 7. And just going back to Dr. Damas's comment before as well, we know that we don't have great biomarkers, as you were sort of alluding to before. We don't really know what biomarkers do you say, this patient's going to recur. We may be eosinophils greater than 55 per high power field. And you're right, testing them, you don't know if they've had a course of steroids and whether that's really an accurate reflection. A lot of our patients are mixed. They're not just pure type 2, they're mixed. So you just don't know who's really going to respond, even though they might tick all the boxes. But these criteria of polyp scores, symptom scores, and I think that symptom score is really important, because you can have patients who are asymptomatic and they're not really going to benefit from that expensive drug, even though it might not look that great. You want to make sure that they're benefiting as well.
Okay. Thank you. Dr. Damask?
I agree. The EPOS guidelines, the EUPHORIA guidelines, recommend, that the patient had previous surgery, and then there's certain kind of check off boxes of anosmia. What's their SNOT 22? What's their
eosinophil levels?
Yeah, stuff like that.
Yeah. Okay. So, sounds like you both use these. And that's what I do too. I use this, it's evidence guided. So, and again, I'm so bummed that this slide didn't pop up, and then this is my shameful plug for why otolaryngologists should be involved in this process of selecting patients who are appropriate. I say, this is not a polyp, that's an encephalocele. This is not a polyp, that's a meningocele. This is not a polyp, that's a JNA. This is not a polyp, it's an inverted papilloma. So lots of things can masquerade as polyps in patients who are extremely symptomatic, but I think that it takes a person in our field with knowledge about all of the different disease processes that can present polyp-like in the nasal cavity, to really put a stamp on patients who may be appropriate, maybe less well served with a biologic. So as we part, any thoughts? I could have talked about this with you for hours. I'm sorry it was so short. Anything you want to add?
I mean, definitely these patients are very complicated patients, especially the AERD patients. They're very complicated. They are very difficult to manage. And these are patients that I really try to work collaboratively with our allergists, immunologists, and even pulmonologists in town so that together we can provide the best care. Because you're right, there are things that we know that they don't know that we can help with. And then absolutely, there's things that they do better that they can help us with as well. And I think together, then we can all take better care of these challenging patients.
Absolutely well said. Dr. Campbell?
Yeah, I agree. And I love your slide about the involvement of the otolaryngologist. And look, I've even seen otolaryngologists who weren't rhinologists sort of not really get the nuances of a various different inverting papilloma versus a polyp, or allergic rhinitis versus chronic rhinosinusitis. So I think having that person with the experience to be able to evaluate that patient with nasendoscopy, plus putting those symptoms together, the adult onset asthma, the early hyposmia, to understand what the eosinophil count means, as well as to be able to interpret that scan to really make sure that they're putting an appropriate person on a potentially lifelong, very expensive medication is so critical. And I'm not allowed to prescribe a biologic for asthma in my country. And so I think that really it should be an ENT surgeon with rhinology training who should be thinking about putting someone on for CRS.
All right. Well, thank you both so much. Our time is now up. I really appreciate you speaking today and participating. And thank you to everyone who joined us. And I think Ted is going to say a farewell.
Thanks, Ashley. Thanks, Ashley. Dr. Kwan, thanks to all of our panelists. These are really excellent, incredibly useful and nuanced panels today. And I know that I probably could have spent an hour on listening to each one. I know you guys probably had a similar feeling, just so much expertise available. So thank you all in the audience for a lot of really great questions. Hopefully we got to most of them. And I understand that this will be available, this video presentation of this will be available after the fact through Storts. So with that, thank you again to everyone in participating. Thanks for the ARS for sponsoring this event. And of course, thank you to Karl Storts for making it all happen so smoothly and effortlessly. And have a great rest of the day or evening or whatever time it is where you are. Take care.